It is now time to begin our Business Ethics in the Treatment of Substance Use Disorder seminar. I am Steve Forzato. I am the Director for the Center for Addiction and Education at St. Joseph's University. I join with Pedro Arrupe Center for Business Ethics, welcoming our in-person audience, thank you for coming, here at St. Joseph's University. In addition, we have our virtual audience. We are broadcasting this virtually to 18 states, as well as Washington, D.C. and Puerto Rico. So welcome from your homes outside of Pennsylvania or your offices this afternoon. On October 22nd, 2012, Hurricane Sandy hit the east coast of the United States. Its high winds reached 115 miles an hour, and its storm surge wreaked havoc not only in the United States, but also in 8 countries, especially those in the Caribbean. An estimated $70 billion in damage occurred before the storm finally subsided just 10 days later. The federal government released billions of dollars to help repair homes and businesses damaged by this storm. Contractors, we watched them. They flooded the east coast of the United States, especially the Jersey Shore. And they came with the promise to do their job and restore businesses and homes and essentially restore families by helping with the relief effort. Among the many well-intentioned contractors were a small group of profiteers who took money but failed homeowners. Whereas 300 people died in this terrible hurricane, America has lost hundreds of thousands of people in just the last few years due to the hurricane of substance use disorder. Research shows that nearly half of us here in this teletorium at St. Joe's, half of those that are joining us by Zoom, we know someone, we personally know someone who has lost their life to substance use disorder. Government, insurance companies, and the courts have responded to this hurricane, putting billions of dollars into treatment. While most treatment practices are patient-focused and offer evidence-based, ethical, and effective treatment, there are some who put profits ahead of patients. Like contractors who scammed people at our Jersey Shore, there are unethical treatment centers that are failing patients and their families. Profit becomes their motive. What are their harmful practices, and how do we hold them accountable? Helping us lead this conversation is the president of St. Joseph's University and a strong supporter of the Pedro Arrupe Center for Business Ethics and the Center for Addiction and Recovery Education. Please join me in welcoming Dr. Mark Reed to our podium.
Good afternoon, everyone. Let me add my own note of welcome to St. Joseph's University, to those present here with us, as well as those joining us virtually via Zoom. It's really my pleasure to introduce our keynote speaker today. Josh Shapiro was elected Pennsylvania's Attorney General and took office in January 2017. He represents and advocates for the Commonwealth and its citizens to protect people's rights, to ensure a fair, level, and equitable playing field, and promoting, of course, the common good for all. As Attorney General, and most relevant to today's forum probably, he and his office have prioritized addressing the critical issue of drug overdose, especially resulting from opioid abuse and addiction, and have challenged companies, organizations, and individuals to be accountable for their actions, or lack thereof, that have caused or contributed to the problem. All the while, Mr. Shapiro has focused not only on adherence to the law, but also set clear expectations for ethical conduct and responsibility. This forum today is sponsored by the Center for Addiction Recovery and Education, as well as the Pedro Arrupe SJ Center for Business Ethics at St. Joseph's University. So it is my pleasure on behalf of St. Joseph's University to welcome Pennsylvania's Attorney General, the Honorable Josh Shapiro.
It's wonderful to be back at St. Joe's University. And Mr. President, I want to thank you not just for the warm introduction, but for giving me the opportunity to stand at this podium again and to discuss a topic that I know can make some people feel a little bit uncomfortable. It's hard to talk about these issues. And yet this is the second time I've been in this auditorium talking about an issue that impacts people's lives in a really deep and meaningful and emotional way. The first time actually was talking about the clergy abuse investigation that we did. And I say that because here at St. Joe's, it is clear to me that with the leadership that the president provides and the atmosphere that you create, you want to create an opportunity to have meaningful dialogue, deep dialogue, and push people into areas that maybe they feel a bit uncomfortable, that challenges them, and that hopefully allows us to not just learn something from a purely academic perspective, but learn some things that then allow us to go out in the community and make our neighborhoods better and stronger, and in this case, save lives. And so I truly want to thank you for creating that environment. It's always an honor to be invited here to speak. Thank you. And I want to say hello again to my former colleague, our former Deputy Chief in the Office of Attorney General, Steve Forzato. He's moved on to bigger and better things, and we're really proud that he's continued to do work to try and save lives in dealing with the opioid crisis. So truly, Steve, thank you for your friendship and for your leadership. I know you're going to hear from some of my colleagues in the Office of Attorney General a bit later. And while I'd like to just talk about the crisis that we find ourselves in today. And if I walk, hopefully you'll be able to hear me, and the folks at home will be able to hear me as well. Maybe I'll grab this. We find ourselves in a situation across this Commonwealth where we are losing 14 Pennsylvanians each and every day. 14 brothers and sisters and aunts and uncles and moms and dads and children every single day. And I can tell you, having traveled all across Pennsylvania, rural, urban, suburban communities, this crisis knows no bounds. It doesn't respect municipal boundaries, age, geography, race, you name it. You can't be rich enough to avoid it. Everyone is affected by it. 14 Pennsylvanians each and every day. Now, we believe in the Office of Attorney General that drug addiction is a disease, not a crime. I think when you begin the conversation that way, particularly as a law enforcement agency, it allows you to both address the crisis, and then it also puts you in a position to see the humanity in others. It allows you to make the criminal justice system work in a way that is not just punitive, but demonstrates that it has a heart. I learned a lot about this when I served as county commission chairman in Montgomery County. You heard the president talk about my biography. And one of the first people I met in that role and looked up to, and still look up to, is Judge Steve O'Neill, who's here from Montgomery County, who started, I'm going to say the first, he can correct me later if he wants, the first drug court in Pennsylvania, and one that has seen thousands of people come through the door and be given a second chance, an opportunity, be able to overcome their addiction, turn their life around, and be able to look out for themselves and their family and their loved ones. And it's with that in mind that we approach this crisis. Now, look, to be sure, our job is to make sure that those who are breaking the law are held accountable. 8,200 people who are dealing drugs in Pennsylvania since I took office have been arrested for their criminal conduct. 8,200 from all across Pennsylvania. So we're making those arrests. We've seen a more than 150% increase in the number of arrests of doctors who are utilizing their medical training, and other health practitioners as well, who divert legal prescription drugs for illegal use. We're arresting them as well. You know, we try and track these drugs back to their source. Where'd they come from? What's the supply chain coming into our communities? Jerry Daly at the HIDA does a lot of that work.
But you see, we understand that it's not enough to just find the drug supplier to that street corner. You got to look at the problem from a real holistic perspective, a broad perspective. And the reality is, if you want to understand who's supplying these corners, who manufactured this crisis in the first place, well, then you can't turn a blind eye to the executives at the pharmaceutical companies. And with that in mind, 4 years ago, I began an investigation together with 3 other attorneys general from across the country, 2 Democrats, 2 Republicans. It should be a nonpartisan activity. We began investigating some drug manufacturers and the 3 distributors. Fast forward 4 years later, a lot of hours, a lot of trips to Cleveland. We kept meeting in Cleveland, which was not like, no offense to Cleveland, but not where you want to be. We were able to hammer out a $28 billion settlement with 4 companies, 1 manufacturer, Johnson & Johnson, along with 3 distributors, McKesson, AmerisourceBergen, and Cardinal. ABC is actually based here in Montgomery County, or there in Montgomery County. And the reality is, as a result of those hard negotiations and getting nearly every attorney general on board across the country, we were able to secure those billions of dollars and then divvy it up amongst the states based on population and how hard they were hit. Now, based purely on population, Pennsylvania should have gotten about $700 million worth of those $28 billion. Instead, we were able to secure $1.1 billion because of both our population and because of the impact on Pennsylvanians. That $1.1 billion, we then worked out with leaders across the state to divvy it up as follows. 70% of those dollars are going to make their way through the county human services departments, or whatever they're called in the local counties, to go out directly to treatment providers like many of you here and many of you watching on the Zoom. Another 15% or 15 cents in the dollar will go directly to the Commonwealth of Pennsylvania, appropriated through the traditional process. And the final 15%, I think that equals 100, goes directly to municipalities and counties that we're litigating. So in effect, 85 cents of every dollar is going right back in the local community. One thing I insisted upon during the negotiations was that you couldn't use any of these dollars to go to filling potholes. And while infrastructure investment is real important, it shouldn't be done with these dollars. We wanted 100% of all this money to go into treatment and treatment-related services. And so actually part of the legal settlement includes a document that spells out all of the permissible purposes for these dollars. So for those of you familiar with the tobacco settlement agreement, where those dollars really were siphoned off for extraneous or unrelated purposes, that can't happen here. Now, the responsibility of every attorney general was then to get all their municipalities on board. We have 67 counties in the Commonwealth of Pennsylvania. And I'm pleased to be able to report to you that all 67 counties signed on to this agreement, which means Pennsylvania will now receive its full $1.1 billion share that is going to go to treatment here in these communities. Now, it's critically important. And by the way, there are other investigations and other settlement discussions ongoing with other companies. The worst of the worst, of course, being Purdue, which they have run to bankruptcy court. They're there trying to shield as much of the Sacklers' assets as possible. We're going to keep battling them there. And then there's others, Teva, Endo, and other companies as well that we're going to continue to work to bring resources back. But this is a model now for what we need to do in this country with all of these companies that have culpability, that were part of manufacturing this crisis. And that is take some of their ill-gotten gains, return them to the people, in this case of Pennsylvania, to get the help that they need. Now, I talked in the beginning about this law enforcement agency and the chief law enforcement officer of the Commonwealth of Pennsylvania. My responsibility is to make sure we arrest those who are breaking the law. And then we have to have a multidisciplinary approach to do that, from the drug dealers to the doctors to others. But at the end of the day, it is my view that law enforcement is not going to solve this crisis. And for as capable as these women and men are, who work in my office and the others in law enforcement who do this work, Reality is, even though it's a multidisciplinary approach, if someone asked me what's the one thing we need to do to really address this crisis, in reality, it would be treatment. Be making sure that we have treatment available to more and more people across the Commonwealth. With that in mind, we obviously negotiated this settlement, but it's also why we've engaged in other activities in the AG's office to try and bring people closer to treatment, to make sure that there's no wrong door when someone turns for help. Under the leadership of Dr. Janine Holter in my office, we recognize that a lot of people trust local law enforcement. They trust their local police chief or their local police department. And when they show up at those doors to the police department, if we could just give them the ability to walk in and ask for help without being judged, then we might be able to break down another barrier that stops people from getting help. And so under the leadership of Dr. Holter, we started something known as LETI, the Law Enforcement Treatment Initiative. We're now in counties across Pennsylvania. I think we're up to about 16, and I'll be announcing a couple more later this month. You can walk into that police department. You can say you're there for help. And the local law enforcement has been trained to be able to match up with the local treatment community and get someone into a treatment bed or get them into a treatment slot. And now with the added $1 billion that's coming in, there'll be more and more treatment available, especially in our rural communities that are really underserved with a lack of treatment. The LETI initiative is an example of what we should all be striving for, and that is to break down any barriers that exist for people getting the help that they need, to eliminate the stigma associated with getting the help that people need. And so when people can look at someone in a uniform, maybe a little bit differently, that they're there to offer a helping hand as opposed to a pair of handcuffs, then all of a sudden people's perceptions change and their willingness to ask for help and look for help changes as well. The work that you do day in and day out is so critically important. And part of the reason why I wanted to be here today is not just to brag about the incredible work that our team does, but to really get the chance to thank all of you from the treatment community for the work you do. I'm excited to see what you will do with the added resources that we've been able to bring back to the Commonwealth from this national opioid settlement. I'm hopeful that the legislature will put more dollars into treatment as time goes on, and the city and the counties will as well. At the end of the day, you all are on the front lines doing this hard work. And I just want you to know how grateful we are for your service and how critical you are in this process of both eliminating the stigma associated with getting help and then providing really quality service. That is what's going to turn around these terrible numbers that, again, claim the lives of 14 Pennsylvanians each and every day. I'll end with this. The president talked about how I'm the product of a Jesuit law school. They let a Jewish guy into a Jesuit university. And I'm someone who takes my faith very seriously and studies other faiths as well, and enjoy being in an environment where faith gets integrated into our teaching and into our conversation. And there's a teaching in my faith, which I reflect on actually daily. And that is that no one is required to complete the task, but neither are we free to refrain from it. And while it may be a Jewish teaching, not Jesuit teaching, the reality is I think we can all find ourselves in a position of understanding what that really means and embracing that message. That really each of us has a responsibility to get off the sidelines, get in the game, and do our part. There is no one individual here in this room that can possibly be responsible for eliminating those 14 deaths every single day. But if each of us does our part, if my team makes the arrests and brings the cases, if a university like St. Joe's is willing to open up its doors to educate people about this scourge and do something about it, if those of you on the front lines are able to do your job to treat those who come in and need that help, if those who provide the support services can hug that mom that just lost her son due to an opioid overdose and turn that mom's grief into some kind of meaningful work to help others, then we can begin to bend this curve and save lives and address this crisis. And so each of us has a role to play. And I would argue each of us has a responsibility to do that work. And so I really want to end where I began by saying thank you. Thank you for not just having me here today and giving me a few moments of your time, but thank you for the meaningful work you do. It all fits in to the broader effort here to save lives and to deal with this crisis, to deal with it in a humane way, to understand that drug addiction is a disease, not a crime, and to make sure that we save lives in our Commonwealth. So I appreciate the opportunity to be back at St. Joe's University and to address all of you. And with that, I'll turn it back to Steve Forzato. Thank you very, very much.
At this time, I'd like to introduce a St. Joe's alum and a great friend of the work that we do here in collegiate recovery in our Arrupe Center for Business Ethics, as well as the Center for Addiction and Recovery Education. This alum really did start an incredible group of programs where St. Joe's is truly standing with those in the margins and living up to our Jesuit values. So without further ado, I would like to welcome to the podium Brian Dooner, great friend of St. Joe's, and as I said, an alumni.
I think it's wonderful that you have the opportunity to hear the Attorney General, hear the President of the University, hear the Director of our center talk about this issue. And, you know, it's been about 5 years since I approached the university and said, you know, we should start talking about addiction and, as importantly, recovery, because it's a topic that is all too often not discussed. It's actually part of the disease of addiction to not talk about it. And so by the formation of the center, by the work we're doing in collegiate recovery, I've often said, I'm proud of the fact that St. Joe's is leading the conversation about this topic. And so when I say it's a dream come true, I mean, we just heard the Attorney General. We were able to poach, I think is the right word, Steve Forzato as our director from the Attorney General's office. Steve and his team were able to secure a grant for the Center for Addiction and Recovery Education within 6 months of its formation during the height of the pandemic for the school to train first responders all over the Commonwealth of Pennsylvania. And some of those trainers are here today. And it's just incredible for me to think that this just started with an idea and of course, a little bit of money from me and my wife to start this ball rolling. But St. Joe's has taken up the mantle. And what we saw here today was a conversation about this. And I also said in that process, because of the folks that I know, I want to introduce our center and our campus and our student life. There's microphones everywhere. And I'm hitting them all. Introduce all of the facets of St. Joe's to arguably the most important national partners in this treatment space. And you know, whether you consider this a public health issue or a public policy issue or a healthcare issue or a criminal justice issue, you can see how interdisciplinary it is, or a social justice issue, and that speaks to our Jesuit stuff. It touches all of those things. But to have access to the largest nonprofit treatment providers as friends of ours, as partners of ours, is a real blessing. And Joe Garbely's become a friend of mine. He's the chief medical officer at Caron. I don't get the opportunity to introduce Joe, but I do want to introduce my very good friend from Hazelden Betty Ford Foundation. And I hope you'll talk a little bit about Hazelden. Hazelden is the reason the Minnesota model is the model of treatment that we all enjoy today for the ultimate in clinical care. But Bob made the trip and I drove down and picked him up and played chauffeur today. He flew in from Minneapolis this morning. And it's really an honor to have Bob here. So I want to welcome my friend, Bob Poznanovich.
And thank you for giving us the opportunity to talk about a topic that I have a lot of passion about, and that is addiction and recovery. I think I also want to really welcome all of you who aren't in suits and the students here today for being part of the discussion. I think so much of what we know about addiction recovery is wrong. And what we really don't know about is a lot of the topics that we're going to be talking about today was the fraud. So I just want to start by saying that addiction treatment works when it's a good treatment. People do recover, and nobody has to get worse before they get better. I think that's one of the myths that I always like to defend, because you might have heard this, maybe some of you have heard this, that with substance abuse, people have to hit bottom. And that's cruel. In no other disease in the world would we ever say that somebody has to get worse before they get better. So I wanted to start with that. And again, thank you for being here. And thank you for having the chance and the opportunity to carry on the message. And I really appreciate the St. Joe's and the Center for having this topic, because this topic isn't talked about enough, and it's a huge problem. I really appreciate the staff from the Attorney General's office and also what the Attorney General talked about the willingness to take on this fight, because we need to. And this is the uncomfortable truth about our industry, that there are many unethical providers. Most of them are also illegal. And the work that they're doing is creating millions of dollars in profits for them, while many of us are struggling to survive and even to live. And then all of those that we touch, including the families, they have to deal with the consequences of our addictions. And legitimate treatment providers like us and the Caron Foundation have to compete in unfair competitive practices, where we're following laws and following rules and following ethics and following mission. Many of these organizations are chasing the dollar. So we've got to fight to keep our reputations intact, differentiate ourselves from these providers, and to compete in the face of these scandals, which does no good for the overall industry, which also comes under attack and under the myths that this is hocus pocus. And as I said, treatment doesn't work. But this fraud that's been going on in the treatment industry has been going on for quite a while. And I think, though, that we are starting to see improvements in some of the laws that are changing, some of the activities that you have in your state, and some of the states that have been plagued by this are starting to take action. I'll share some of that with you as we go through the presentation. But the reason this fraud has been taking place is because of money and greed. There's a lot of money in the drug and treatment business. A couple of years ago, it was $42 billion in revenue from the treatment industry. And it's estimated to grow by 53 billion in a couple of years. And I've even seen the number higher now for a couple of reasons. One is the Affordable Care Act made substance use treatment a coverage, an essential coverage under benefits. So it's opened up more and more people to get care through insurance. And today there's about 3.7 million people getting care, but there's millions more who need care. And when investors from private equity and venture put together the growing availability of patients, the growing need of patients, combine that with the apparent, significant increase in people needing care because of the opiate epidemic, and then anticipated the funding that's going to be coming in through some of the opiate settlement funds, they thought they could carve out a piece of their market amongst those 1,400 providers and saw opportunity for a gold mine. Now, this is the exception. It's not the rule in addiction treatment. Historically, a lot of the people who are in the treatment business were people who were ma and pa. It was a cottage industry who got in this for good intention. There were people whose families recovered from addiction and they started small treatment centers around the country. Some of those merged and created bigger organizations. And some of the ones like Hazelden and Betty Ford and the Caron Foundation became the largest in the country. Most of the players are really good. But there's been those driven by profits. And when they got into this business, they didn't realize how difficult it was. And I would meet with a lot of venture people who try to recruit me or try to get some advice. And they would say, we see this pyramid of only this much people are getting help. And we see $30,000 per patient in revenue. And it's a good business to get into. And I would say, can't you go find a fan company somewhere that needs help in creating new fans? I'm like, get out of this business. We don't need that kind of money and that kind of a mission coming into this business. But yet they chase the promise of the profit and the gold mine. And this topic is even more important today because of what is coming around the corner. COVID is for sure the most psychologically traumatic time that any of us have ever experienced, and one of the worst times in our history. We are seeing a population that is much sicker than ever before. The anxiety and fear and isolation caused by COVID has caused a significant rise in those using substance abuse, but also the risky behaviors that are associated with that. 1 in 4 people who are working at home now have, and this is what they've reported. It's probably even higher when you think about the risk of even reporting it. Said that they've been using drugs and alcohol while they're working and doing their video conferencing from home. And 1/3 of the people who use illicit drugs said they're using more. For a long time, the number of people that were alcoholic in this country was about 8%. I just saw a new statistic this week that said that number is up to 9%. And last year, we had the greatest number of deaths that we've ever had just from alcohol. And alcohol, is still, the king and queen of drugs. I don't know about Caron, but at Hazelden, still 53% of the people that we admit. So just that simple red wine drinker could get in trouble too. So it's clear that the workforce that's returning to work today is much sicker than it was when it left prior to COVID. And we're seeing this across all spectrums and all employers. So if you think about the situation we're in, where most people that needed help didn't get help, and now we've added to this a whole new population that are sicker than ever because of COVID, we should be really busy. And we're starting to see more and more people now starting to ask for help where they didn't during COVID. In fact, the Hazelden Foundation had the busiest month we've ever had in our history in March, which is a good sign that people who put off healthcare in general maybe are starting to get care. But what's really concerning about that to me is if that's true and all these people are turning to help, where are they going? Now, 50 or 100 more people came to us than they did last year in March, whatever the number was. But I know there's many, many more people that are going to us in the Caron to get help. And where are they going? For many, many years, I've been in this business. I started a company to try to help families navigate healthcare. And for 15 or whatever it is years, I've been at Hazel doing it too. The way we ask people to buy treatment is part of the problem. I don't know if I have a solution for that except to make more treatment available. But if you think about this, nobody wakes up today and says, the world is great. The cops are thrilled, my family's thrilled, my employer's thrilled, the world is great, I'm going to treatment. They wake up today because something's happened in their life, they're in a crisis. And today might be the day that that good part of my sick mind is telling me that I need to go get help. They probably don't know anybody who's ever been in treatment. They don't know how to shop for treatment. We're asking them in a moment of crisis to do research, whether it be on the internet or other forms of research, without a knowledge about how to buy it, how to compare, or how to reference. And we're asking them in that moment of crisis, over the phone, to make a decision sight unseen about where they're going to go to try to save their life. I think it's the most complex decision that anybody will ever have to make in healthcare. And if you look at the statistics, behavioral health has the lowest conversion rate from those people that know they need help or are struggling to those that actually get help. 2 reasons. One, the addiction is itself as a disease tells you that tries to tell you you're not sick, but then when you realize you're sick, you often refuse help. So that's one bucket. The other bucket, which is the number 1 reason, is a lack of information, what I call analysis paralysis, because they don't know what to do and they don't know where to go. And that moment of clarity where today was the day that I decided I wanted to get help hit me. I talked to a bunch of people on the phone. They all tell me different things. I get confused. I postpone that decision. My crisis is over. And then I'm out there on the run again until the next crisis happens. Unfortunately, I can't control those crises. So that next crisis could be fatal to me or somebody else. In my business, and part of my responsibility at Hazelden is to manage the call centers that take calls. I could tell you that these individuals and these families are so vulnerable, it scares me. I was a small businessman when I opened up my business, but did a lot of good work. I would sometimes at the end of the day just say to myself, what the heck would have happened to these families if they wouldn't have called me? Who would they, who could have, who may have they called? And being as vulnerable as they are, looking for help as desperate as they are, I could have taken those patients anywhere. I could have done anything with them. I think that that's what they face. That, and what we're seeing now with COVID, the phone calls that I hear and I listen to, the recordings that my team sometimes will point to me to say, listen to this, is that they're more desperate and they're more vulnerable than ever now, which is a big opportunity for all of those bad players to take advantage of. In my work prior and in my work today, I spent a lot of time visiting treatment centers. In my previous business, I just made the decision that I wasn't going to send a client of mine to any facility that I hadn't visited. I thank God that I made that decision, because after I visited some of the treatment centers in some of the areas of the country which have the highest rate of bad players, which is Florida, California, Arizona, some of the warm weather facilities. When I went and visited some of these facilities, what I saw on the website compared to what I saw from a facility was shocking. I mean, some of these pictures, I cannot tell you what the treatment environments were like, what the neighborhoods that they lived in were like, and what it looked like compared to the pictures. I went and visited one treatment home that was in the middle of a rundown neighborhood. They didn't even have screens or windows on some of the windows. They had a doctor that was there once a week as they were administering drugs to help people detox from drugs, which is one of the reasons they had a lot of deaths, which was later investigated. I went to another treatment center who offered a form of treatment called residential treatment, where you're supposed to be monitored 24 hours a day, where payers and insurance companies pay a lot of money to staffs like us to have medical, nursing, mental health, chemical health staff on board 24 hours a day. And you were living in an apartment complex where one half of the floor was treatment center. Everybody else was normal populations. And I said, well, how do your people get to treatment every day? And they said, we give them bus tokens and they take the public bus treatment. I've gotten calls from families saying, we made a mistake, and our son or daughter is in Florida for treatment, but we can't find them. Or we can't get them out because the treatment provider won't let them out. And then they do shoddy treatment, and I'm sure you'll talk more about the treatment side of this. But when I said treatment works to overcome one of the disbeliefs about treatment, but it's not just treatment, it's good treatment. And good treatment is defined by that is following the science of the brain science of addiction, following the science of evidence to show what works. And legitimate treatment organizations are using evidence-based practices and following the science of treatment, therapy, and medication to improve outcomes. If you don't know how to buy treatment and you go to a website and they say flower therapy, or you get to play with dolphins, or the one that says wolf therapy has been proven by us to improve outcomes, how do you know when the Caron Foundation is doing research on DNA versus the guy who gets to let you play with flowers? I talked to that patient. She goes, I love flowers. That's where I'm going. I'm like, oh my God, you have no idea what's in store for you. And then there's another area of patient brokering. I'll tell you my story about this one. I got lucky. I'm an alcoholic and I'm a drug addict. I've been in recovery for 27 years. I was intervened on by my drug dealers, which is in itself a whole other story. But he made me watch the Hazelden videotape before he ever sold me the last ounce of cocaine. He goes, you need treatment. I said, yeah, I saw some places in Malibu that I want to go to. He goes, nope, you need to go to Hazelden. I didn't know Hazelden. I said, I want to get sober with the stars. He goes, you'll be better at Hazelden. I got lucky. For some reason, this guy in that day decided to send me to a legitimate place. But you know what he did for a living? He was a tech in a treatment center. And his job was to be a patient broker. And when people would relapse or weren't appropriate for that facility, he got paid for putting people into other treatment centers. He was a dealer in a treatment center, sending people to treatment facilities, either getting paid by selling them drugs or by getting paid by getting them into a treatment. And I'll talk a little bit more about some of those patient brokering examples. Billing, overbilling, and deceptive billing practices are a huge problem and a huge cost for the entire system. Deceptive marketing is something that I'll talk a little bit more about, which we're challenged with today. And I'll share with you what we've done there. And then even worse, and I'll share a couple stories which are just horrendous, which have become in mine as I give this speech, just kind of the cornerstones of showing how bad this industry has gotten. But thank God that there's a lot of people like the people at these tables today that are taking these predators down. And a lot of us in this industry call them predators because that's what they are. So fraudulent billing is submitting claims for services that aren't provided, or forging attendance records, or coaching patients on how to fill out or how to conduct their medical interviews to create a condition that the insurance companies will pay for. What really troubles me, along with the next line here about drug testing, where we're billing people sometimes every day for a test that runs between $500 and $1,200 for a test that's not necessary, and if it is, it's only a $5 test, is that people who I even view as being somewhat legitimate are also using these tactics. They would say they're legitimate ethical treatment centers, but they're using these tactics to overcome some of the billing shortfalls. A friend of mine who's a well-known man in the treatment industry, and I do believe that he does good care, but he bragged to me the other day about how he is out of network and got an insurance company pay $75,000 for treatment that Hazelden charges $5,000 for. I do think his people got good care, but somebody paid that $75,000 bill. I asked another friend of mine who's been in this industry for a long time, like, how are you competing with some of these bad players? And how are you overcoming some of the reduction in reimbursement that we're getting from insurance? He said, you got to do drug testing. I make up $500 a day by drug testing. And this came from a good guy. And then when I talk to patients, say, I want you to come to Hazelden, but you've got to pay your copay and deductible. And so I talk to the guys in Florida, California, Malibu, Arizona, whatever, and they say, don't worry about it. We got you covered. We'll guarantee you treatment. We'll guarantee you 30 days of treatment. And we'll help you pay your copays and deductibles and any out-of-network costs. Here, they can't make those promises, but they do. And some of that is illegal. And they even go as far as being illegal is that they will buy insurance policies or pay COBRA or buy insurance policies while people are in treatment, get them to pay for treatment. And then there's a side of the incentives. A big part of the fraud in this industry has come from an unregulated business called sober houses, which is where somebody will buy a house, depending upon the rulings in that area. They could put maybe 5 to 10 people in a house. They'll put double and triple rooms. They'll charge the residents a lot of money, and they'll have loose guidelines about staying sober to be able to live in that house. Since it's unregulated, nobody really knows what kind of controls go in there. But what we do know is that these sober houses are working very closely with unethical treatment centers, and they're passing dollars back and forth between them to create inducements for patients. So treatment center will say, go to this sober house and I'll pay for your rent. The sober house will say, when you relapse, I'll send them back to that house. So they're paying incentives for people to get referred back and forth. They're paying incentives for people to relapse. So it's pretty common in a lot of markets where they've got inundation of a lot of treatment centers and sober houses that patients are getting paid to relapse. And then they're getting paid incentives to finish treatment. So let's say I'm in treatment and I'm getting $500 a day from insurance. The treatment center is getting $500 a day, and I say I want to leave early. The treatment center would say, "Don't leave early. I'll split the money with you. I'll pay you $250 a day to stay in treatment." Or they turn those patients into recruiters, and they say, when you go out into the community, look for somebody that relapsed. You don't have a job right now, you're new in recovery. I'll pay you $500 to $1,000 for every patient that you find, that relapsed, to go to my treatment center. They provide free gifts. Travel. It's something I have to overcome all the time, is travel. As a nationally recognized center, I have people from around the world come to treatment. And people pay to come to our facility. I was saying with Caron. But these other treatment centers are saying, we'll give you free airfare. We'll get you a ticket down here. And again, it's just another way of competing, but then they give them other incentives as well to come to treatment. And then what often happens is, obviously, when you get there, you're full of surprises. And then in most cases, they'll get billed for services that they didn't know they're going to get billed for. And they'll be somewhat held hostage in those facilities. And I talked about the amount of opportunities for sober houses, professionals, drug testing companies, unethical individual providers to create this web of fraud exists in ways that is really almost like the old RICO laws within the mob. They're so intertwined together, and they've got all this figured out, including the brokering of not only patients, but the laundering of money as well. So it's a complicated network. And if you're able to get past all of those concerns about how people are incenting you to go somewhere, you have to deal with the black cat and different types of marketing. But think about this in closing on the incentives. Think about if you're in the ambulance and you're having a heart attack. Instead of the ambulance driver driving you to the closest place that's going to be the best care, they drive you to the place where they're getting a $50 kickback. And it's worse than that with substance abuse. And then if you survive all of that, then you got to think about, is the marketing you're getting really what you think you're getting? And is the site that you're visiting really the site that you're thinking about? It's gotten so bad that Google, for only the second time in history, had to put in place a process to validate the advertising by treatment providers. The only other time they did it was with locksmiths. Now, I didn't realize that locksmiths were that shady of a business, but they put treatment centers in line with the locksmiths. And people had to go through a pretty extensive process of validating their organization, their behaviors, their ethics, their accreditation in order to get authorized by Google to advertise on Google. And a lot of organizations were unable to make that. But that was one of the things that Google did to try to clean up the industry. I don't know how much you could see. You actually see it okay. So I had a customer call me, or a patient call me and said, I want to show you this ad. And they sent me this ad. They said, we called this place and it didn't sound like Hazelden. So this ad, which ran in one of those websites, showed a picture of our facility, talked about us as an organization, et cetera. When you call that number, the staff there answers the phone as the national call center. I said, so I secret shopped them. I said, is this Hazelden? They said, it's the national call center. Never said we were Hazelden, but never said they weren't. What was even scarier was I called twice. One of the men and one of the women were great. They were great on the phone. By great on the phone, I mean that they understood empathy. They know how to engage with me. They know what questions to ask. They know how to motivate me to continue to get help. I would have hired them if they were legitimate in a second to work for us, because they understood substance abuse, they understand the family challenges, they understand what I as an addict felt, and they would have convinced me to go to treatment there. And after a few minutes on the phone with them, they said, you know what, Bob, I think the best place for you would be to go to our place in Tennessee. I said, I didn't think Hazelden had a place in Tennessee. And then they got kind of mumbly and the conversation went sideways. But how would a consumer know that? If you were told by your doctor, your family, your friends to go to Hazelden or Caron, and you go to the website and you think you're calling and they don't tell you you're not, next thing you end up and you're in that crap hole in Florida that I saw with no windows, or you're living in an apartment complex with everybody around you not in treatment. You're taking a bus to treatment. I just Googled Caron just for the heck of it yesterday. Karen's name came up. I will say the good news is that's your phone number, but that's not your website. It's in a competitive treatment center's website. They also put their phone number on there too. So maybe you got a 50-50 chance of calling them or you. I also Googled just fraud in the industry. There are so many articles on this that I couldn't pick which article I wanted to share with you. So I just went with the screen that I already had. But Google fraud in the substance abuse industry. You'll find hundreds of articles, some as current as a few months ago, about people who have done horrible things to patients, from kickbacks to fake surgeries to unapproved FDA ways of implanting medication. And it's even gotten to hospitals. So the lure of the money and the profit has gone beyond some of these, these creepy owners in small communities. Several hospitals too were recently found guilty of conspiring to work with some of these organizations where they were laundering money. So it even goes a little bit deeper than just some of the small. That's why I talked about this network of dollars and following dollars is pretty complicated. But the worst story that I use on this topic is a man by the name of Chapman. This guy is a poster guy for predators. He was a felon from New York City who robbed people out of money when they bought and sold cars in the car business. After he got out of prison in New York, he went to Florida, which has a disdain, or has had a disdain for regulations and for laws. And he was allowed to open up treatment centers and sober homes. He did everything I talked about and worse. And the final thing that he got, that he did, was that he held some people, as they call it, human traffic, that they were captive in his sober houses, and others he turned out in prostitution, and that many people of his care died. The Attorney General for Florida, and I think specifically the Del Rey, said, we've got to do something about this. People around the country are trusting us to treat their families, and we're sending their families home in body bags. He just got sentenced, by the way, for 27 years, so good for them. And if you think about the impact this has on the families, I mean, it's hard enough to get into treatment, but then you go through this process of distrust and the safety concerns. We talk about treatment really working by creating this therapeutic alliance of trust between the treatment industry, the treatment providers, and the patients and the families. That length of engagement, how long somebody stays in treatment and stays in treatment in the continuum of care, is important to their outcome, to eventually give them hope or self-efficacy. That whole model is blown with this type of fraud and abuse. I can't trust my treatment provider. I can't trust the industry. I'm not engaged as long as I should be. Where do I go next for help? How can I trust the next phone call? It's a challenge. And us as providers, we have a challenge with this. Our reputations are on the line too, on who we refer to better understand, and we need to understand now their clinical practices. It's no longer okay for us to just use Google either to find resources for individuals. The payers are working on trying to solve this by putting laws in place that makes it harder for people to go out of network. Some have gone to where they only allow you to go to the state next to you. And that's a step in the right direction, but that assumes good treatment exists everywhere, which it doesn't. So by limiting some of the fraud, they're also limiting people to really good care. But I appreciate what their efforts are. And others are creating centers of excellence strategies where they're identifying the top providers and trying to promote and incent people to go to those locations. And the big problem with this has been those providers, those treatment centers that are out of network. So they're not really controlled by any insurance companies. They're not regulated. In a lot of cases, a lot of markets, they're not even licensed. So a lot of plans are being developed that eliminate the opportunity for anybody to go to an out of network treatment center. And this is one of the reasons why, from a cost perspective, that everybody's trying to focus on this. A patient who goes to an out-of-network, non-center of excellence treatment center, according to Cigna, which is one of the largest health systems in the country, says the overall cost to the consumer and to the payer is 3.5 times higher to go to a place who may not be following the sciences, may not have the history of treatment that many of us ethical and legitimate providers do. Some of the laws that have been invoked recently is the ECRA law, which eliminates kickback in the treatment industry. This law and a lot of the protection from this law existed for those payers, for those providers who use public and government funds, but that was now extended into anybody who's providing care, including the private insurance plans. And a lot of people have been sentenced because of these acts. And in some of the markets like California, Florida, those states and counties have done a lot of work to clean up the work there, but some of it's piecemeal. And they haven't really have gone far enough. And it is state by state. It really needs to be national, because as they close down one market, they open up in another market. But for example, California just didn't go far enough. They created a law that says you can't do all these things, but they left open travel. They said, as long as you're giving a round trip ticket, it's okay. I'm like, well, how is that okay to provide that incentive? Because California didn't want all the people homeless on the beaches dying from overdoses who got a free ticket in, who didn't get a ticket home. I'm like, go a step further. Don't allow any travel. Make some of the other tougher decisions that you have to do. And what we're doing about it is we're taking the fight on to Congress. We've had a chance to testify, our CEO, alongside other of the ethical treatment centers and leaders in the industry, as well as some of the people who have been the bad players who were put on the spot. We're working alongside our National Addiction Treatment Center, our industry association, to weed out those and not allow membership to those who don't pass the smell test. And we're taking the battles to courts whenever we're impacted. That one company that I showed you that took our name, created that ad, we sued them and we won. So we're going to continue to put our face forward to do something about this. And we're taking all of our knowledge as an organization, sharing it with other providers to help make them better. And part of the settlement that we had for the company that we sued was that they had to go through some of our training on what ethics are and some of our curriculum and to change their ways. And then I built a patient care network, which is I no longer refer to people that I haven't vetted, that my team hasn't vetted, that we've done a complete background check on them, that we visited their location, we understand their, we've done research and hit background checks on their owners. We've looked at their certifications, licensing, criminal records, and public records. Because my brand and my brand promise also extends to those who I refer to or those who might need care after my care. And I need to make sure now the people that I send people to do good care as well. And then my final thoughts before I pass it on is that at the end of the day, what we do, what the legitimate treatment centers do is that is the focus that we have on our patients and communities that we serve. That's why we exist. It's our culture that drives the ability to be successful in meeting these needs. But we must remember that what we get, society, is what we reward or what we tolerate. So I thank all of those who are here representing the Attorney General's office and all that you've done in your state and all the other states have done to not to tolerate this and not to say it's acceptable. And that all of us have to continue to work together in events like this to spread the word, to share the knowledge about the unpopular truth about what we're doing. Because, the old saying about caveat emptor, let the buyer beware, doesn't apply to healthcare. So thank you all, and thank you very much for giving me the opportunity to say the word.
Our next speaker is an SJU alum and the Chief Medical Officer and Executive Vice President for Medical Strategy, Education, and Research at Caron Treatment Center. He is sought after to speak to national audiences on the treatment of substance use disorders. Please join me in welcoming one of SJU's very own, Dr. Joseph Garbely.
Thank you, Steve, for that wonderful introduction. And I just want to thank Attorney General Shapiro and his team who are doing just amazing work, and it needs to continue. It's going to take a village to fix this. And that's thank you for all the work that you do. And thank you for that great talk, Bob. Some of what I'm going to talk about will touch on what Bob talked about. And my wife also asked me, do I ever get nervous about this speaking in front of crowds? And I said, no, I don't, because I like to hear Bob's voice. I've been a member of the board at the American Society of Addiction Medicine. That's 7,000 strong. So 7,000 healthcare professionals strong. And I've been on the board for 3 years. I just came back from the meeting and then was unanimously elected to a second term. And my role there is to try to bring addiction medicine education into all healthcare higher learning. So we've been able to pull in addiction medicine to all the medical schools, PA schools around, also for nurse practitioners as well. Because again, education is going to be part of how we change this. When I went to medical school in the 80s, oh gosh, I feel older and older every day I walk here on this particular campus. But I can measure in hours my education in addiction medicine when I was in medical school. That's changed. Now it's woven through the entirety of medical school, who have created their own curricula to meet core standards that we created. And that's true with all the other schools, the allied health schools as well. And nursing training is so important. And we have all these folks on our campus, just like they do at Hazelden, Betty Ford. And we're trying to train a workforce so that they can identify and treat addiction. If they don't know what they're seeing, they won't diagnose it and they won't know how to treat it. So that's part of it. This is the definition that I was privileged enough to work on. And you can see that addiction is a chronic disease, or substance use disorder, I should say, is a chronic disease. It's preventable and it's treatable. It's stress-induced, genetically mediated primary chronic disease of brain reward, motivation, and memory, and related circuitry. What we see in treatment is actually the dysfunction of these circuits leading to biological, psychological, social, and spiritual. So if you don't touch on all of these domains, you're not going to have successful treatment. And many of the bad actors that Bob mentioned, they have one treatment paradigm, and you go there and they put you in that treatment paradigm. There is no treatment plan that is tailored to the patient. And there is no multidisciplinary team, which Bob mentioned has to happen, to treat the patient. And you really need to treat the co-occurring mental health and the co-occurring medical issues that occur, or you're not going to have success. So the last part of this definition is this is reflected in an individual pathologically pursuing substances for reward and or relief. So, and that relief part is what we're seeing mostly after the pandemic. The COVID-19 pandemic actually accelerated two epidemics, the mental health epidemic that we're currently experiencing right now, and of course, the substance use disorder epidemic that we're seeing as well. And the isolation will do that. It's like gasoline on a fire, especially for substance use disorder and mental health issues. But recovery is real, and I want to just stress that. So I'm going to, try to keep this on a more upbeat on a more upbeat platform. So 22.3 million Americans, 9.1%, or 1 in 10 are in recovery. And I'm here to say that I am in a long-term recovery. I'll have 24 years in June, God willing. And you see that in the treatment industry across the board. It's what you do with that, right? What you do with your recovery that matters, and how you can create evidence-based polydisciplinary or multidisciplinary teams that can really address not only substance use disorder, but mental health issues and also medical issues. So 75% seeking treatment achieve a remission. So you could see that it definitely works. The risk of reoccurrence decreases after 90 days, and at 14 months, recovery is more likely than relapse. It takes that long for that to happen. And at 5 years, you have the same risk factor of going on to relapse as someone has in manifesting the disease of addiction, somewhere around 12 to 15%. So if you can stay in a lifelong journey of recovery, your odds get better and better that you'll stay there. And that's really quite important. Average number of treatments are 5. So we don't want that. We want to try to get this done. So when they come to your treatment facility, that they leave in recovery and stay on a lifelong journey of recovery. So here's the big but. Current state of the treatment sector does not support long-term recovery for many individuals, especially those with opioid use disorder. The risk of relapse for someone with a heroin use, for example, disorder, without medication-assisted treatment, or the new term is medication for opioid use disorder, is around 90%. I'll say it again. The risk of relapse is 90% if all you get is detox. And the consequences can be deadly. So if you're in detox, you are released and you begin using heroin that's filled with fentanyl, synthetic opioid that's very potent, then the chances are that it might be a one and done situation. Thanks to Steve Forzato and his team for training first responders to utilize naloxone, which is a reversal agent. The number of lives saved because of his work and the work of all of our first responders is really, a part of the village, right? You cannot treat the deceased. So they are there on the spot, overriding the overdose. And this is just showing just how bad it has gotten. So we've gone the wrong way. The pandemic helped us go the wrong way. There was 100,000 overdoses. It was actually over 100,000 that occurred in 2020. And the pandemic was certainly a part of all of that. But as you can see, it's sort of a linear curve going the wrong way, up and up and up. In 2018, we started to think we're turning a corner. And then, you start to see numbers in 2019. And then, of course, with the pandemic, the numbers keep rising. And Bob mentioned that there was an increase in the number of alcohol-related deaths. That's 95,000 deaths from alcohol-related conditions. And that's a high watermark as well. It always has been around 80, somewhere in the 80s, around 88%, and 88,000 rather, I'm sorry, that died from related alcohol use disorder. So if you put those together, we had about 200,000 deaths just from addiction that was quite avoidable if people received treatment for it. So what we have is this really a goat rodeo, which is chaos, or we're like trying to herd cats to fix this, right? So we have good people like Bob and Hazelden and Betty Ford working with us in conjunction. Caron's been around since 1957. Hazelden's been around since 1949. And I can honestly say that we have a wonderful relationship with them. We share information, we lock arms, we help each other have the best treatment possible. And we're also out there advocating for new laws to change things and to get rid of the bad actors. So we cherish our relationship with Hazelden, Betty Ford, and many of the other good treatment centers that are around the country, because that's who's going to set the tone going forward. So the substance use disorder treatment field is a fertile field for problems. So it's underserved. So not enough people that have addiction will get treatment. And those that are underserved in general, people of color and other diversities, they are woefully underrepresented in the treatment community. And there's a misunderstanding in our field We're undercapitalized. There's this strong need for revenue and profits, especially in the for-profit side. And there's an under-regulation that's occurring. I'm an internist and critical care doc. And then I went back to do a residency in psychiatry. And now I am an addiction medicine physician. So I had a circuitous route in medicine, let's just say, but they all complement one another. And they and it's really the internal medicine background that really speaks to me, because in other parts and parlances of medicine, outcomes are so important. And in this field, they have just not been collected. They have not been outcomes that you can trust. They're self-reports oftentimes. So we need, as a field, to be judged on our outcomes. That needs to start to happen. And we need to look a whole lot like some of the other fields in medicine, like the orthopods and their knee replacements. Too many infections or complications, your reimbursement rate's going to go way down, and you're not going to be referred patients as a result of those statistics that are readily available to the population seeking the replacement. So this is about underserved populations, and this is about those that have a substance use disorder. So more than 40.2 million Americans met the criteria for substance use disorder in 2020, and that's through the National Survey on Drug Use and Health. And only 6.5%, I'll say it again, 6.5% of that 40.2 million who needed substance use disorder actually received it. And only 1% received the type of treatment that we're talking about here at Hazelden, Betty Ford, at Caron, at Ashley, and some of these other treatment facilities that can actually handle the co-occurring mental health issues, along with the trauma issues that occur, and also along with the medical issues that are inevitable, especially with alcohol when they come in for treatment. And I agree with Bob, we've just been seeing sicker and sicker patients. We actually have a program now with the University of Pennsylvania, and they're sending us their liver transplant patients. They have waived the 6 months sobriety because too many people were dying waiting to have that 6 month mark be met. So they are doing the transplants with no sobriety. And then they're sending them to us so that we can pick up where they left off and move and then help these folks understand what is substance use disorder and how do you get in recovery and stay in recovery and have that journey for life. More than 200,000 deaths, as I noted before, the 100,000 overdoses, the 95,000 alcohol-related deaths. The stigma and anonymity, many in recovery don't talk about it, nor do they advocate it. They sort of stay hidden. That's changing. You can see some prominent voices that are putting their hand up and saying, I'm in recovery this many years, and they're, giving, a face to what recovery looks like. So some of the barriers, the belief that substance use disorder is rooted in personal moral failure and weakness. So that idea of a lack of willpower and also moral failure, that stigma is still present, unfortunately. Education is a vital part of that. We need to educate the workforce so that they do no longer think of it in those terms. And we need to normalize, there's a normalization of excessive substance use or prescribed medications. The stigma I mentioned, there's shame that comes with this disorder. I always say it's a chronic disease, but it's an evil disease. It's the only disease that'll tell you you're well and you don't need treatment. So that's something that we have to, work on with the patients so that they get into treatment. There's a lack of a firm diagnosis oftentimes that doesn't allow patients to get into treatment, a lack of access to treatment. There's this fail first model. So you have to fail a lower level of care to get to a higher level of care, and patients may not make it. If they fail the lower level of care and they overdose on fentanyl, you're not going to see them in the higher level of care. So that does not work. A lack of unbiased information as well that we need from our patients, and a lack of outcomes and standards to determine what is good treatment and where to go. We spent the last 3 years becoming a trauma-informed campus. So this is a tremendous amount of effort went into this. We trained everyone from our environmental care folks all the way up to the executive team. And we took many different tests and we became a trauma-informed campus. But you'll see that others claim that without doing a lick of work as far as getting that moniker and becoming a trauma-informed campus. And that just isn't, that's not okay. That couldn't happen in cardiology. It couldn't happen in nephrology. You either are or you're not. You can't just claim it. See, I always say that substance use disorder and the treatment of substance use disorder, that field grew up outside of the medical industrial complex. So what that meant is that many of these treatment centers opened without licenses. They opened it without any kind of accreditation from the Joint Commission or CARF, and there were no standards being met. They could say whatever they want. Bob mentioned wolf therapy. They called it lupine therapy. It was out in California, and I guess if you came out alive, that was, you know, the beginning of your recovery. I guess you were scared straight. Maybe, I don't know. So I never understood that, but apparently that was happening. But no more, thank God. And then the other thing is the anti-medication assisted treatment, new word, medication for opioid use disorder stance. So there's been a fight that has gone on since dated 2000, when we were able to use buprenorphine in the office to save lives. These are life-saving medications. Methadone, life-saving medication. Vivitrol, extended release, life-saving medication. These are all medications for opioid use disorder. But unfortunately, many treatment centers did not buy into that. And they were anti-medications for opioid use disorder, which made it very difficult to get the patient to the next level of care, which oftentimes we want it to be a good, sober living place like Hogan Hall, or a good place, a good recovery house. But they said because they're on medication for opioid use disorder, we will not take them. So they're denying the patient from life-saving medications that reduce cravings and keep them from overdosing. So the lack of understanding also about different types of care. This is the ASAM placement criteria. I am an editor, full disclosure, for the residential chapter, which is 3.1 and 3.7. But I think it's important to understand that not everyone has to fit into a residential treatment paradigm like Hazelden Betty Ford has and we have. We also have every level of care, as does Hazelden Betty Ford, so that the patient goes where they need to go. And the criteria really helps you understand exactly where the patient needs to start their journey. It isn't a fail first thing. It's not dictated by insurance. It is academic in nature. And so I'll skip detox for a second. Outpatient is 1.0. That's where the medications are often prescribed. Relapse prevention occurs there. And then you can move up to intensive outpatient, about 10 hours a week, 3 days a week. As you can see, it's more intensive than the outpatient groups and individual therapy that happen at the outpatient setting. Partial hospitalization is a very popular setting for treatment centers. So they have a sober living area, and then they're taken to campus, and then they spend a day, like 9 to 3, for treatment. So that's down in Florida. We have a Florida campus, and it's called day-night treatment. So they stay in sober dorms during the night, and then they come to campus during the day. We're a residential treatment facility, and oftentimes that gets mixed up with inpatient, which really gives fits actually for DDAP and some of the folks that come and survey us for our licensure, because it actually doesn't make sense. They are kind of mutually exclusive. So residential is 3.1 to 3.7. We're a 3.5 and 3.7 institution in Wernersville, Pennsylvania. Aftercare recovery support, we start that on day of admission, and we have to find out who's with us or who's against us. So when we were going about trying to find the right trusted servants that we can send folks to after they're done their treatment in our residential setting, we just spent a lot of time knocking on doors, talking to people and finding the right mix across the country. We get patients from 46 states and 13 countries. So it was quite the endeavor, but we definitely told them, if you don't take medication for opioid use disorder, then you're no longer going to get a single patient from Caron. We think it's that important. And guess what they did? They started taking because they couldn't afford not getting the referrals that we were sending. So again, continuing medications for opioid use disorder and alcohol use disorder, very important. Peer support groups is something that we offer at Caron. And then the sober home and recovery housing issue is an issue that needs attention. DA Aronson down in Palm Beach, we have our treatment center right there, Palm Beach County, has done a wonderful job shutting down these rogue, if you will, recovery houses and sober homes, because they're run by people with good intentions who are in recovery. But it's like the wild, wild west, like that goat rodeo that I showed you. So again, here's detox. So detox as treatment is not treatment. And I'll explain to you what the relapse rates are if you just get detox. There's a lack of individualized care in all substance use disorder treatment in the bad actors. Hazelden, Betty Ford, Caron, and others, we definitely individualize care, and it evolves over time. Treatment center drives treatment plan, not medical needs of the patient. This is what I was saying. This is our treatment. We're going to put you in there. You're now a widget that we're going to put you into our treatment paradigm. And then if you relapse, it'll be your fault. That's exactly how the treatment industry has conducted itself for all too long. Resistance to medication for opioid use disorder is still present. Like I mentioned, treatment focused on morality, still the stigma. Slow adoption of chronic disease model. It's a preventative and treatable chronic disease. Think diabetes, think hypertension. We've been treating it like pneumonia, which is an episodic treatment. It's like hanging IV antibiotics, and then when the pneumonia clears, good luck. But it really should never be that way. We should be following our patients all along. So we follow every single patient that comes out of our residential center for 1 full year. And we do that so that we could be peer supports for them. We can take away any obstacles to their aftercare. That we do not interfere with their aftercare, but we collaborate with their aftercare. We also have an arm where we get random toxicology. So their self-report is, I'm doing fine, but then we find opioids or we find stimulants in their urine, which portends, a relapse and a discussion around that. The bad actors don't use evidence-based practices. Near as I can tell, lupine therapy never went through any kind of studies. It never was published. Maybe in wolf journals, if they exist, I don't know. And there's no accepted and there's definitely inconsistent outcomes. And that's what I want to focus on here at the end. Lack of complete abstinence is treatment failure. We have to change that. People are going to they're going to slip. It's a chronic relapsing and remitting disease. So there's going to be relapses, and we can't just chastise the patient because they relapse. We have to figure out a way to bring them back into recovery. So that has to happen. Harm reduction, we, Caron, embrace that now. And it's so important because different patient populations need to be availed different strategies. Harm reduction is one of them. So this is the broken reimbursement models. Bob talked a lot about that, so I'm not going to go into it too much. But managed care was really focused on cost. The MDs were not trained in substance use disorder, so when you were trying to fight for another week of treatment, you were talking to somebody who's never had any training in substance use disorder, just had a script which ended in no, apparently. They focused on costs, not outcomes. Prescriptions for pain and behavioral health fueled addiction crisis as it continues to do. It's acute and episodic, like treating pneumonia. And inpatient goes, there was a lot of private pay. Right now at Caron, we're in network with Aetna, all the Blues of America, Capital Blue Cross as well, and many other insurance companies. About 2/3 of our beds are filled with insurance folks. And payment models reward relapse. So in the budgeting process, they budget for people relapsing and coming back to their facility. And it's a way to make money. So it's well-meaning individuals without training credentials who are the backbone of this particular part of this treatment center, the bad actors. County authorities are understaffed, underfunded, rules vary from county to county, and housing issues and aftercare placement are difficult, especially for those with medication for opioid use disorder. And then there's a lack of regulation and outcomes. Patchwork of regulations is state by state. So again, I mentioned it's a cottage industry growing up outside of mainstream medicine. Licensure not necessary to become a provider, so the actual facility is not licensed. No oversight can open without. So these sites can open without any accreditation. They don't need to pursue accreditation. We are CARF accredited and also CARF ASAM accredited. Regulatory hurdles still exist, and that's got to stop. We have to eliminate the pre-authorization. When I was at ASAM, Dr. Chorizo Cunningham, who is the commissioner of substance use disorder treatment for New York State, was able to get that done. And that needs to happen so that we can get life-saving medicines to patients. And then predatory marketing, I think Bob did a great job with that. I'm not going to go into it too much. We certainly have a disrupted market. Substance use disorder is an epidemic that was hidden by the pandemic. It's gotten worse, not better. The opioid crisis is with us. It's worse, not better. Private equity money has made its way into our industry and has poured quite a bit of money into the industry. But that means there has to be a return. So there's a real concentration on revenue and cutting costs. And we see that even in the treatment centers in this area where they've had reduction in force, RIFs, just to reduce costs because they did not have the revenue. And mom and pop treatment centers can't compete. Insurance and cost control measures are not there. There's a litany of misconduct, which Bob went through, and I won't go through too much. But I want to talk about, and this is just some headlines of some cases, thanks to you guys over there for intervening and stopping Liberation Way, amongst others. So the public really has lost, they've lost the credibility. We've lost the credibility for the public, I should say, and they think treatment's a scam and addiction is hopeless. So this is just kind of cut to what I want to finish with. This is our CEO Emeritus. I've testified multiple times at subcommittees, as has Doug Tiemann, our CEO Emeritus. I've done Hill briefings as part of ASAM. I've lobbied congressmen and senators to try to get some laws passed, which we've been successful and then not so successful. So we need to create new laws, new standards, new enforcement. This is just, all that goes into really good treatment, and it needs to be the model. This is John Kelly from Harvard, and he listed all the different things that should be present in a treatment facility. And then you can see that on the right here. But as I'm running out of time, I'm just going to keep on going, and you guys can read it at your leisure. And then, so the co-occurring rate of mental health is off the charts. At Caron, it's 90%. So the focus, if you think about it, medication is really important in the limbic area to reduce cravings and calm those cravings down and need to leave the facility. So plants their feet in treatment. And if you look at the targeting, In the cortex, that's where counseling comes in, helping with the decision-making, thinking, reasoning, and planning, and giving them a strategy to do so. So this is just looking at some of our outcomes, because I think it's important. I presented at the RX Summit in 2021 with the CMO of Independence Blue Cross, Dr. Rich Snyder. And we went into a program with them in 2017, and the outcomes year in and year out are these outcomes. So you could see that we had 5.6% readmission rate within 90 days. Now, we took a risk. So if anyone relapsed within 90 days, we paid for it. So we needed to take that risk. And only 5.6% actually, needed treatment, and that was on our dime. But what happened is that they saved a tremendous amount of money, and they went to Highmark, and that's how we got the Blues of America. They went to Aetna, that's how we got National Aetna. And then you could see here just more of the same as we continue to get data from them. Best in class, along with Hazelden, Betty Ford, of course, outcomes. And then this is our Aetna outcomes that are brand new. Our Aetna contract didn't start too long ago, but you can see here that only 3.7% have relapsed within 30 days. That's the data they have thus far. We'll have more soon. And their benchmark is 9%, and most providers don't hit the benchmark. They're 9.6%. And then you can see here that getting to that next level of care, that linkage, we're up at around 71%. They like 70%, but the other providers are around 60%. And that's what we need to be. We need to hold ourselves accountable. We need to have outcomes like that. And if we don't, then you need to be held accountable for that. So there's never a right time to do the wrong thing. So thank you so much for your attention. And I want to mention this textbook that there's a forward in here from myself and Dr. Mike McCormick, who works with me at Caron. We're both Hawk alum, and it was written by Dr. Sillip, Dr. Giovanella, and Dr. DeLuca. So this is a textbook that I know you're all going to be reading and learning about opioids, a prescription for crisis. So thank you.
Thank you, Dr. Garbely, for your remarks. Really appreciate it. And our next presenter is the director of the Pedro Arrupe Center for Business Ethics and a professor in the Department of Management, Halb School of Business at St. Joseph's University. He earned his Ph.D. from Temple University, an MBA from Drexel, and his bachelor's degree with honors at Rutgers. In business, he held senior management positions at Telecordia Technologies, the Unisys Corporation, and AT&T. He has an impressive publication record in business, press, and journals. In 2021, his case study, Business Ethics in the Substance Use Treatment Industry, Greener Pastures Recovery Center, was not only published by SAGE, but received the 2022 Editor's Choice Award for Healthcare Management. In other words, the publisher recognized Dr. Swift's work as the best of the best in their curriculum collection for classroom utility, originality and concept, timeliness of subject, and quality of writing. Please join me in welcoming one of SJU's very own Dr. Timothy Swift.
Thanks for coming. I see some of our students are here, both in the room and I'm sure online. So before I get a hand in this question, yes, this will be on the exam. Please pay attention. What I'd like to do for the next few minutes is talk about how we're trying to bring the topics for today, the experiences that our experts have described into our classroom. And we're doing that as best as we can through the Jesuit tradition of taking these issues and these important decision points through formal moral theory and helping our students develop normative business decisions as to how ethical business decision makers might navigate through this difficult time. But I think there's also a subtext here that we're trying to achieve, and that is through my time at St. Joe's, I think this is my 14th year, it's been very apparent to me that almost all of my students' families have been touched by this awful disease, and that this campus certainly has suffered from this disease. And so this is an opportunity for us to talk about this in the classroom and to have our students maybe learn a little bit about the real life experiences that are in this case study and to relate it to some of the experiences they may have had in their lives and may have in the future, okay? So before I talk a little bit about how we went about this case study, I want to recognize and thank the Dooner family. Where is Brian? Brian Dooner and his wife have been very generous supporters of today. Mr. Dooner contacted me a couple of years ago and said, we really need to raise awareness on this issue. It's going to be, an important theme and an important part of St. Joe's mission. We need to have a symposium. And I thought that was a great idea. And then the pandemic hit and we had to postpone, but finally, I commend everyone's diligence and we're finally here. So I want to thank Brian and his wife for their generous financial support and their encouragement for me to delve into this type of research, which was new for me. So here's how I thought I might be able to add value as an educator at St. Joe's. I tried to make some connections and build a case study. Qualifiers. This case study is built upon real life characters. Everyone in this case is familiar to me, and I've brought them in to this imaginary case and had them interact just based on my imagination. The criminal activity, the unethical decisions that are in this case really happened. There are characters and bad actors in this business case that really exist. And I want to thank Steve Forzato, who introduced me to the fantastic work that the Attorney General's office has done in successfully prosecuting these cases. So I have a feeling that our prosecutors here in the room might see some things that ring a bell in my fictionalized case study. But here are the connections that I tried to make. When I was 9 years old, I went to a Catholic school, big surprise, St. Joe's, and this priest who was a missionary from Haiti came in to talk to us kids in the cafeteria about the missions. And he held up this enormous pair of pants, real big fat pair of pants. And he was a regular built guy. And he said that these were the pants that he was wearing 5 years ago. But based on the diet that was available for him living in Haiti, among the people of Haiti, he had lost this much weight. And then, of course, we had the slides that we all had from slide projectors back in the 70s. And he showed a picture of himself when he arrived in Haiti, and then a picture of himself on that day. That was enormously upsetting for me as a kid to think of being deprived of food. Maybe the first time in my life that I was really impressed with what it was like to be deprived of the basic necessities of life and the real suffering that's occurring in the world. So over the years, I've always had a special devotion to those that serve the poorest of the poor. Man, I always just thought that those were like the Marines. Those were the really special forces, good men and women, if they go out to serve the poorest of the poor. As I lived my life in Philadelphia, I realized we don't have to go to Haiti or Africa or any of the other corners of the world to encounter and serve the poorest of the poor. I found them in Kensington, which is my wife's old neighborhood. And not only are there people suffering from the disease of substance use disorder there, living in abject poverty with inadequate housing, clothing, and diet, but they suffer from a special kind of poverty that I had never encountered before. They've lost their families. They've lost love and companionship and physical relationships because so many of these people had fallen out of the fabric of their lives. And so I try as best I can to work down at St. Francis. I work at St. Francis Inn as often as I can, and I help serve meals to the folks that are suffering from homelessness and addiction in Kensington. These people are in this case study. People that I know by name are in this case study. The main character in this case study that I'm going to describe in a little bit is a guy named Mitch. Mitch could be a typical student at St. Joe's. Mitch is a composite of many students that I've known here at St. Joe's. Colleen and I raised our family up in Bucks County. Mitch is based on a lot of kids that I knew that lived up in Bucks County. Mitch liked his drinks. Mitch liked to party. Mitch started to drink hard before he visited his friends because he couldn't drink as much as he liked in social settings. So as the kids were saying, Mitch started pre-gaming. Mitch found that he could manufacture a perfect buzz by taking what kids call Xannies along with his alcohol. Mitch began to experience, the pleasures involved in taking synthetic opioids. And after his income ran out, Mitch, like so many people that I know and love in Kensington, resorted to the use of heroin. And Mitch found himself on the streets of Kensington among the people that I try to help every Tuesday night. This is a fictional character, but I can name people, and I'm naming them in my head right now, who have taken this exact path. So these are good kids from the right families that have taken reasonable risks. If you talk to the typical young people that like to party hard, and these people, not all of them, but far too many end up in Kensington. So Mitch is someone that I know and love. The countless families suffering from this pandemic, too many to name. Many of my best friends up in Bucks County, where Colleen and I were moms and dad, were a mom and dad for 20 plus years before we moved back into the city. Some of our best friends were grieving as their children disappeared for days or weeks or months, or sometimes never came back and sometimes died from this disorder. My case study has those real families and tries to draw, from my own amateur perspective, draw light on how this disease impacts families. I know unethical recruiters that operate in Kensington. Those folks are in this case study. There are folks probably with the very high social capital that some of our expert speakers have mentioned today, who know how to read a person, know how to find the person that's in that perfect place, who can say, you know what, I think you've had enough of this. There's a house in Ambler, Pennsylvania. I'm not saying Ambler, sorry. I'm saying a nice suburban area outside of Philadelphia. You can get out of Kensington, 3 hot meals a day, a warm bed. Treatment will help you get back on your feet, help you get back in touch with your family. Come with me. And they're pulling these people out of Kensington with the right promises, with the right words, pardon me, but with unethical intentions in terms of how they're going to serve these people. Okay. I have a fictional character in this case named Mary. Mary is Mitch's best friend, as his last companion, as he's living on the streets in Kensington. Mary went with one of these recruiters. Mary was off the streets for 6 months. Mary came back to Kensington and very, very quickly overdosed and died. I know a couple Marys, okay? And I'm not down there a lot. I'm only one of many workers down there. And I know a couple Marys who went to these centers, came back in worse shape than they, maybe a couple pounds heavier, but in worse shape than before they left. And they fall back into old uses and then die from overdose. And then lastly, there are the families that are seeking safety and community in Kensington. The stakeholder that I see, in addition to those mentioned today, are the good residents of Philadelphia, particularly the good residents in the neighborhood of Kensington that are trying to raise their children in the faith, in a good education, who are coping with tremendously unsafe neighborhood conditions as they navigate family life in this neighborhood that's being devastated by this scourge. So these are the themes that I tried to use from my own experience, where I add a little color commentary to create a realistic ethical dilemma that I could turn over to my students and say, what should these people do? Okay, so what's the problem? As I just mentioned, Mitch has been through the worst of it. Mitch had lost his family. Now Mitch is living in lasting sobriety. Mitch has a special place in his heart for the poorest of the poor. Mitch remembers Mary, thinks and prays about her often, and wishes now, as he's in lasting sobriety, to take a step to help other people reach sobriety as he had. So Mitch has a vision of creating a substance use disorder center that would treat the poorest of the poor, the people that are closest to his heart. He builds with another buddy who's in recovery with him. He builds Greener Pastures Recovery Center. And the mission and the business model is to serve only the people from these difficult neighborhoods, because Mitch understands that folks that have private insurance or maybe a certain level of financial security already have options for treatment. So Mitch and Kevin try to create a center that is serving people with very, very little economic means. Okay. There's financial difficulties. I did the best I could. I forgot to mention my co-author, Justin Stout, who was our Arrupe graduate assistant when Justin and I wrote that. Justin is now a medical student and setting the world on fire. Justin and I did the best that we could to research what are Medicaid reimbursement rates for these therapies that these patients need. What are best practices in terms of what sorts of therapies these, and what would they really cost? I'm a business professor. I laid out the income statement. And then for my top line, we put Medicaid reimbursement rates. It's not a good model. It's not a good model, right? So Mitch and Kevin, and hopefully someday we're going to run this case study through an accounting class, because if you want to look at the income statement and the balance sheet, it's a nightmare, right? So these entrepreneurs very quickly run into financial difficulties. I bring their families in. Who rescued Mitch, who was who was the first blessing that Mitch received on his path to recovery? His wife of many years, who stuck out her hand and said, let's get this done. And his wife and their children are paying the price, as now Mitch is losing his ability, even in sobriety, to support his wife and children. His children are paying the price for these difficulties that he's encountered. They're confronted with unsavory ethical decisions. And essentially, the ethical decision that Mitch and Kevin are faced with is, do we need to give up our dream of fighting for the poorest of the poor that suffer from this disease? Or is there some way we can make this work by being a little bit more aggressive in our business practices to try to make this work? And then, you know what? I bring in everything I would from a business curriculum, violating the mission that was carved in stone the day that we set up this, forgetting our vision, not keeping an eye on our true stakeholders, letting the line get blurred once. And as I learned many years ago from my mom, the first time a sin doesn't bother you, boy, oh boy, from then on in, it's a piece of cake. So there's a trail for our students from a best practices perspective to understand how business models fall apart and how poor decisions tend to snowball. And ultimately, the case ends with representatives from the Pennsylvania Attorney General's office calling and asking for a set of meetings. Okay. What sorts of things take place in this case? And I'm going to go over this because our experts today have already explained these in vivid detail. There's a fictional character who really operated in Philadelphia, a guy named Mark Rossi, fake name, real guy, who did very well working the streets of Kensington and elsewhere, finding patients, finding those people that were ready to take a chance and make a change. And Mark Rossi is one of those guys who can go to a struggling treatment center like Greener Pastures and say, I can fill these beds at top-notch reimbursement rates. Don't ask too many questions. Unnecessary drug testing is going to sound familiar to my prosecutors in the room. Greener Pastures was testing patients at the highest levels of reimbursement rates up to 10 times a week. When their facilities were finally rated, there were stacks and stacks and stacks of urinalysis tests that had never even been read. But yet the bills had been put through and the center had received that. Burned out physicians who were no longer on premises were filing stacks of blank prescriptions that were being filled out by uneducated, underpaid, frustrated staff members. Insurance fraud. I hope that this is an actual detail that occurred in real life. But one of the last straws that launched this investigation is that a very good insurance investigator noticed that there were several people in a certain geographic area who were being placed on platinum reimbursement, the highest rates of reimbursement, platinum insurance plans on clusters of days. And on those same days, treatment centers began billing them for inpatient substance use disorder. So in other words, hey, here's 35 people from the same zip code, from the same street address. All of them signed up for the Obamacare, right? Private insurance that was available on the public exchange. All of them just signed up for the most expensive health insurance there is. And the day they signed up, I'm receiving bills from Greener Pastures Recovery Center. These guys aren't as slick as they needed to be, okay? So folks are being, and by the way, the details that are in the case is this victim who's being brought in, these men and women that I feel like I'm beginning to know and love in Kensington, they're brought in and they're told that you're here on a scholarship. We've got a scholarship and that scholarship is going to pay for your insurance premiums. Well, the insurance premiums coming from operators like Mark Rossi, because if I can start billing the day you're on that plan, this is beautiful cash flow, okay? The houses where people like Mary lived, and my experts here have already mentioned this, were centers that were designed for relapse. The groundskeepers, the men and women that were cutting the grass and trimming the hedges and maybe fixing leaking faucets, they were dealers. There was sexual activity encouraged between residents and even residents and staff. These are not conditions for sobriety. Why? Because as these gentlemen have already mentioned, there's nothing like having someone relapse and re-enrolling them for another round of treatment at these reimbursement rates. So these people were placed by design in situations that cycled them through multiple rounds of treatment, okay? So what do we do in the classroom? How do we try to bring this to life for our students? Not just to give them a taste for what's happening in their city or in the suburbs where they may have grown up, but how can we take our Jesuit tradition, our formal moral theory, and work through what should be done in these cases? So we take them back to philosophy 154. Maggie, is it philosophy 154, moral foundations? Thanks, Maggie. So we take them back to utilitarianism and rights theory. We're back to Kant. And we review how we sort out, Michael's laughing at Kant, how do we sort through the rights of individual persons when they come in conflict? We look at utilitarianism. How can we proceed through this in a way that creates the best net benefit for society? So we do a primer on things that they've learned in their Jesuit academic core. Then we identify the stakeholders. Who has a claim here? Who must we care for as men and women of and for others? And not only who's at the table, but rank them. Who should be cared for first, and who may need to give the most in terms of deciding the most ethical path forward. We have dozens, hundreds of vulnerable people in recovery. Their recovery center is about to be shut down. Mitch and Kevin still have the reins of the company. They're still married. What should they do, right? How should they rank all these people that are depending on their decision, okay? And we talk about where did they go wrong? This is what I'm going to call classic business school curriculum. What sorts of tactical mistakes did they make in terms of being highly skilled professional managers that need to make decisions? I think my students that are in the room would agree. One of the things that's often picked up is the mission was so clear and was so inspiring. And early on in the case study, there's a fairly innocuous decision where Mitch and Kevin see a way to improve profit margins. And we're just going to ease a few of these lower income folks out. Just a few, right? Well, that was never the mission. That was never the mission. So I'm very proud of my students for seeing how the mission that drove the creation of this, that attracted so much startup capital is now open to be traded for something such as their financial survival. Okay. What should they do? Okay. So, you know, I want to wrap up here. This is what, as a St. Joe's educator, this is what I hope our students are getting out of it. And this is how I intend to use the case study. I can only use a case study for a couple of years because then the students say, here's what Swift's looking for. You just have to tell them this. So, so I'll use this for a few more years, and then I'm probably going to have to write another case study to keep it fresh. But what I'm hoping that happens, and I'm a dad, right? I have two boys that are the same age as my graduating seniors. So I think I'm speaking more as a dad here. I'm hoping that some of our students see somebody they know in this case. And I hope that this brings to life how serious this is and what the end result can be. I know that I have students that I know and love who are hanging out with kids that are just partying too much, right? I know that there are friends that need to get help. Bob, as you mentioned, I need to get help. This is not going to be a very rational day. I need to get help. I've had enough. I have had students who have come to my office, and I'm just a professor. And they come to my office and say, my roommate, my sister, my dad, got to go now. What should I do? And so I'm hoping to bring out to them the perils of choosing wisely or choosing poorly, that our students can bring this back in their personal life. St. Joe's has a service learning curriculum. I'm not here to tout St. Joe's. Well, I guess I am. St. Joe's does our best. You know, Jesuits are men and women of and for others. We're contemplatives in action. We get out there, we get out there. We don't just talk about it. And we do everything we can to get St. Joe's students to serve people in our community. And the cool thing, it's not funny, the cool thing is now that I've been working at St. Francis Inn for the last 4 or 5 years, there's St. Joe's kids that are down there as part of their service learning, helping me do dishes and swing them up. So the kids that can't get into service learning, I want them to know what's going on 3 miles from here, 3 miles from here. The poorest of the poor, not only economically, but also spiritually, are 3 miles from here. And you need to understand it and realize, as our Attorney General mentioned earlier today, that it's our duty to do what we can, even if we can't finish the task. And then I hoped, I don't know, maybe Maggie will tell me later, I hope that I put in front of them a decision that really hurts. Should I let my wife and kid have to move out of our house and go God knows where? Or should I cook the books? Right? I love them. I love that kid. I love that my wife and my kids more than anyone. And would you really, if you were in that situation, would you really let your family, the people that you love so much, fall through the cracks in order to do the right thing? Would you really? And to let them feel the tension and the difficulty that's involved in being an ethical decision maker when your personal well-being is at stake. It's easy to be ethical when you're hitting the numbers. It's harder to be ethical when personal sacrifice is at stake. So that's it for me. I hope that the experts that I'm looking to off to the right can appreciate that we learned. Stephen, thank you for introducing me to the experiences of these experts. And all I can say is I'm doing my best to share with what you've taught us with the students here at St. Joe's. Thank you very much.
Our final presentation today is a panel of experts from the Pennsylvania Office of Attorney General. These are prosecutors and agents that I had the privilege of working with when I was on their team for a few short years after I retired from Montgomery County, Pennsylvania. I had the pleasure of working 33 years in law enforcement, 28 years undercover. While I worked in those 33 years, I had the privilege of meeting some of the most dedicated public service folks from law enforcement. And these 4 individuals did not disappoint me when I joined the Attorney General's office. I want to thank them for their excellent work in insurance fraud, Medicaid fraud, investigations. They have done an incredible job exposing and also investigating, prosecuting unethical treatment centers engaged in illegal practice. Sir Michael Cates from St. Joseph's University will lead this, and I'll ask Michael to allow his panel to introduce themselves to our audience. Thank you.
Thanks, Steve, for the introduction. I'm Michael Cates. I'm a professor of philosophy at St. Joe's University, and I'm the associate director of the Arrupe Center for Business Ethics. And so my teaching and research focuses mainly on business ethics. So most of my day is spent thinking, writing, and teaching about what businesses should and shouldn't do. What's the nature of corporate social responsibility? What's an unfair wage? What should companies do when it comes to climate change? But I don't spend much time thinking about how we hold businesses accountable for the unethical decisions that we've made. And so for that reason, I'm really grateful for the opportunity to speak with a group of people who actually don't just think about what businesses should be doing, but actually hold them responsible for when they do things that are wrong. So I want to start off our conversation by allowing everyone at the panel to introduce themselves, and then we can get into a good conversation about some of the issues that we're focusing on today. Do you want to start?
Sure. Good afternoon. My name is Eric Norman. I'm a supervisory special agent with Office of Attorney General in the insurance fraud section.
My name is Robert LaBar. I'm the Chief Deputy Attorney General in charge of the insurance fraud section for the Attorney General's office.
My name is Doug Hilyard. I'm an agent, section director for the criminal prosecution section for the Office of Attorney General.
My name's Kristyne Crist. I'm a Deputy Attorney General currently with the Criminal Prosecution Section.
Well, welcome everyone to St. Joe's. It's great to have you. And so I wanted to start our conversation by talking about the Pennsylvania Attorney General's office greatest victory in the opioid epidemic, and that's your prosecution in the Liberation Way case. So for those of you who are not familiar with that case, could someone start by talking about, what were some of the charges that you brought in this case, and how did you uncover the main forms of wrongdoing?
Sure, I'll step up to that.
Right.
So Bob's slide had indicated one of those had bad players. It had shoddy facilities, patient brokering, overbilling and fraudulent billing, deceptive marketing. Our Liberation Way case basically had that and then more. Liberation Way was a company that was based in Yardley, Bucks County, and had facilities in Bucks and Montgomery County. We started with getting complaints from different patients, former and current employees, and also some of our insurance company were reaching out and making referrals to us with regard to this. So the agents did a great job, opened up the case, started interviewing, doing all kinds of things, basically going across Pennsylvania, all over. And we found the drug testing aspect of things. There were kickbacks there. Ultimately, we determined there was probably about $1 million in kickbacks. The sober homes, there were sober homes in the whole Philadelphia region that were housing these patients. One basically was named the Party House, which is not something that you want in a drug treatment
Not best
facility.
practice.
Yes, exactly. There were incentives to relapse. There was the out-of-network billing. They were using the Affordable Care Platinum policies to basically bill insurance companies. So ultimately, we arrested and prosecuted the chief executive officer of the company, the chief financial officer, the chief marketing officer, the head of all the sober homes. There were 2 doctors that were involved. There was a lab director that was down in Florida where all the urine tests were going down to, and various business entities that they had set up to basically cover their tracks and try and hide the fact that they were all working together to commit this fraud. So ultimately, we brought state charges of corrupt organizations, which in Pennsylvania is our equivalent of federal RICO. We did dealing in illegal proceeds, which would be money laundering, theft, insurance fraud, and a number of other charges. We worked hand in hand with our federal prosecutors in the Eastern District. And some of these individuals were prosecuted in the federal courts and some were in the state courts. And ultimately, we have got sentences on all of but one of the defendants. Got restitution and approximately $10 million of that involved seizing some assets that they had. And so that's basically how it started and where we're at now.
Great. Maybe someone else on this side of the panel could talk about what the prosecution do you think has done for the victims of the opioid epidemic, the people who are directly affected by this particular case, but maybe more generally the incentive effects the prosecution had to dissuade other bad actors from going into business.
I think one of the issues was that a lot of the people, especially that attended Liberation Way, were then kind of hesitant to go seek treatment anywhere else because all they knew, or a lot of what they knew about the treatment industry, was a facility like Liberation Way that was exploiting their patients and just using them as basically to make money. And I think that are successfully prosecuting both the individuals who were essentially in charge of the sober homes or the treatment facility, and then ultimately closing the facility, gave them, the patients, hope that there are, not every treatment facility is full of bad actors, and that the people who are doing the illegal conduct are held accountable. I still think that there was hesitation to go to subsequent centers, but I also think that with working with other agencies and seeing that the federal authorities, that obviously the state authorities, we worked with other authorities down in Florida, it's nationwide, thing that we're all working together to try to keep stuff like this from happening in the future. So I think that gave them hope that, not every place is going to be detrimental to their sobriety.
Does anyone else have anything to add to that?
I mean, I think it opened up our eyes from law enforcement standpoint. We have a tendency to just think of Pennsylvania. So this kind of allowed us to reach out to our counterparts in Florida. There were conversations with people out in California, Arizona, and we certainly saw some flaws of what we don't have here in Pennsylvania that some of the other states are doing. And hopefully that will, improve in the future here.
Yeah, I certainly think it opened up a lot of eyes, because you can get online and see countless stories about bad actors in Florida, bad actors in Arizona and in California and things like that. And you don't think it's going to happen here. And, here it's happening right under our nose, like right here in our backyard.
Here's more of a sort of speculative question, but maybe this is something that you can have some insight into. Do any of you have any sense of why the guilty parties acted in the way they did? Was it just simply a matter of greed, or was the story a bit more complicated?
I'd say it was strictly greed.
Strictly greed.
It was the money. They might have started, well, they say they started for good reasons. They were all past members of drug addiction treatment centers. They saw a need, especially in the areas of Philly that people couldn't get treatment. So they opened it, I think, with good intentions. As they opened it, though, they saw that private equity was something they couldn't turn down. The private equity then eventually turned them to do nothing but boost the numbers as high as they could get it, so they could essentially go to a private equity sale where they could all walk away millionaires. So these are guys that are, down on their luck on the streets 3 years prior, that are walking away 3.5 years later millionaires. And I think that clouded their judgments throughout their process of running the center.
Does everyone else on the panel agree? It's a simple story of making more money?
Oh, absolutely.
Yeah.
They were totally greed motivated. And I mean, these aren't guys that were worried about being able to pay their rent. I mean, they were living a life of luxury.
Right. Interesting. All right. So one of the lessons that I try to teach my students when we have a business ethics course is that what's legal and what's ethical are not always one and the same thing, right? So for example, sometimes the law in this country has prohibited behavior that it's not unethical. So interracial marriage is an obvious example. And conversely, not all unethical behavior is contrary to the law. So I tell my students, it's wrong to lie, it's wrong to commit adultery, but it's not against the law. So I was interested to know, therefore, did you uncover any unethical behavior in this case that you weren't able to prosecute through the law? And if so, how did you feel about having your hands tied, so to speak, about not being able to do something?
One of the biggest things that we found in our case, and it occurs in all the cases, is the patient brokering. One of the reasons a lot of treatment is looking towards Pennsylvania and moving up the East Coast is because of more stringent regulations, such as in Florida, who passed anti-brokering laws. Once that happened, a lot of the patients and stuff you saw get pushed up the East Coast and eventually into Pennsylvania, where we do not have patient brokering laws or stringent regulations, where they can continue to do what they've been doing for so long and benefiting significantly to it. So we did have patient brokering. We could prove and charge some of it, but we did see, patients being shuttled essentially all over the country to different treatment centers under the guise that this treatment wasn't going to work, so we have to go to another treatment center, maybe of a higher level care for you. And the backside of that, they knew exactly what they were doing. They themselves had participated in it as patients at some point, and they continued to do it even though the cost of what was happening to the patients.
Any other examples?
Well, I think the housing that they set up was also unethical, the way they had it set up. Like Rob said, I mean, one was kind of referred to as almost like a party house. I think somebody else referred to them as a frat house. So, I mean, they're knowingly pushing their patients into these housing situations that they know are going to be conducive for relapse. And if that happens, they can just cycle the patient back through the program again at the highest level of care, where they're going to make the most money from the insurance companies.
Sort of as a follow-up question, can any of you think of any legal reforms that would, make your job easier or enable you to prevent more unethical practice in the future? I imagine that you have the power to put into law whatever you think is necessary. Can you think of any good ideas that would make your jobs easier?
I mean, certainly following in the footsteps of some of the other states that have enacted patient brokering laws, I think that definitely would be a step that we would encourage to see, and we'd be able then to prosecute that unethical behavior that we saw, but we weren't able to actually go after.
Any other major reforms you can think of?
I think this would be more towards like state regulatory, like the agency that regulates the treatment centers and sober homes. The way that Liberation Way operated, they were licensed for outpatient services, but they essentially operated as inpatient because they had sober homes that on paper were not affiliated with the treatment center. But obviously through our investigation, we found were completely intertwined. And they had the patients stay at those sober homes and then would shuttle them to the treatment on a daily basis and then go right back to the sober homes. And unfortunately, because of the way that it looked on paper, it was a loophole essentially where the Department of Drug and Alcohol Programs, who oversees, this is a regulatory agency for the state of Pennsylvania, they were unable to control and to regulate those sober homes. So I think closing that loophole would also be something that would be beneficial in the future.
One thing I've noticed today in our discussion is the enormous difference in behavior between on the one hand, nonprofit organizations like the Hazelden Betty Ford Center and the Caron Treatment Foundation, and on the other hand, the behavior of for-profit entities like Liberation Way. So in your experience, are for-profit entities more likely to run afoul of the law? And if so, why?
I think it goes to your initial question of what they did. There's the greed aspect. So if there's a financial incentive, then there's always going to be that slippery slope that they're, going to make that ethical decision to, hey, let's cut a little corner here, make some more money, put it in my pocket. So I think the for-profit certainly, it encourages that.
Does everyone else agree?
Yes.
The for-profits are tough, especially when you have the nonprofits, because the for-profits are the ones that are sending pictures of the beach. You can stay in Malibu, you can stay on the Florida Keys if you wanted to. And when they actually produce or get the patients there, then they run into the fact that it's not anything that it appears on paper. So, I mean, it is tough. The for-profits, like this one started with the belief that they could help people. And then at the end, unfortunately, the money just took over.
So do you think that it makes sense for states like Pennsylvania to allow for-profit treatment centers to continue in business, or should there be more stringent regulations about the business models that are allowed to help patients?
I think you have to have for-profits, just because there's such a need for the treatment industry right now to have the adequate facilities.
And you're worried that if there wasn't such entities, then there would be fewer people trying to
Correct.
help those
Right.
who need it.
And that was our biggest obstacle with this case, was we knew there were hundreds of people in this treatment center that were not necessarily being harmed, but not receiving the treatment that they were supposed to be getting. And it was a real touchy situation where we don't want to shut a treatment center down and put 300, 400 people out in the street the next day. We had to have contingency plans in place that, other treatment centers could absorb them. And that was one of the biggest problems, was when they eventually did stop allowing intakes, which helped. It drew it out over a couple months where their population slowly decreased. Whereas if we would have shut it off one day, there would have been no recourse or no available resources for 200-300 drug addicted people to receive treatment immediately that next day.
Similar thoughts on this side?
Yeah, agreed.
All right, so here's where one sort of maybe concluding question, then we can open up questions to the audience. So you're prosecutors and you're dealing with behavior after it happens, and you're dealing with the victims of these problems. Can you think of any ways that we as a society, not just as members of government, but members of academia, members of business, can help to work to prevent these types of problems from happening in the first place?
I think as long as there's money to be made somewhere, this kind of conduct is always going to occur. It just will occur at a different level.
Right.
I mean, again, I think having the specific laws in place, unfortunately, we're talking about the patient brokering laws now.
Yeah.
Of course, 5 years ago, they weren't really on our radar because it wasn't something that we were seeing or that we were aware of, even though it was happening in the background. So I think just continuing, to try to do the type of work that, at least we're doing on our end, and to educate people that this is out there and that, things can be done to try to curb it and then enact whatever we need to in the future, in terms of law or regulations or what have you. I think that's the only way that's going to kind of put an end to the conduct. But I think, in terms of, at least here, as long as there's money to be made,
Right.
people are going to find a way to make it.
Does anyone have any other suggestions?
Well, I think laws and kind of regulations that would be set into place, they always seem to be kind of reactive. So problems identified and solutions made, whether it be a law or a regulation or something. But it seems like in my years of law enforcement, it seems like the criminals always find that soft spot. So as soon as you harden one spot to where it's going to prevent them from doing what they're doing, they're going to find something else. And
So you're always playing whack-a-mole.
yeah, very much so. The one thing that I will say in this case is one of the things that kind of brought it to the forefront quickly was there were people that were either former employees of Liberation Way or current employees of Liberation Way that took the initiative, that reached out to DDAP and said, hey, look, we're working here, we work there, we don't like what we see, we think, their behavior is criminal. So, I mean, those people had the initiative and the drive and the courage to come forward and say something about it. And that wasn't an easy thing for them to do, because one of the things that Liberation was able to do with the profit that they were turning is they were able to pay their employees more than you can make at any other drug and alcohol rehab around here. So they put these employees in a spot where it's like, I don't want to bite the hand that's feeding me, and I'm not going to go get another job anywhere around here and make the same type of money. So I give those type of people credit, and I think they're almost like the front line to avoid things like this in the future.
All right, so we have some time for some questions from the audience. I believe there's some microphones around. Steve?
Hi, Jerry Daly from the HIDA program. On the subject of regulating sober houses in particular, we know that is changing in Pennsylvania, and that I think it's the June 1st, DDAP will be able to start fining licensees or persons without licenses operating sober homes according to the standards that they have. But it only applies to a certain select group, namely those that are receiving state or federal funding, those that are being having referrals made to them by state agencies, county agencies that use those funds. What would you do to broaden, I guess, the scope of those regulations and hold accountable people outside that set of circumstances?
that was one of our biggest obstacles with this case was that DDAP had no inspection oversight or control over the sober homes that were associated with Liberation Way. On paper, it appeared they met all the DDAP requirements. They weren't funded or owned by the actual treatment center. However, behind the scenes, when you did the financial investigation, you saw that they were. They were nothing but shell companies that bought these houses third removed or the sober homes third removed, and the money was just a continuous flow back in. DDAP, it's a great step forward, but I think they need to continue and go more forward, that if you're a registered sober home, you need to have some oversight by either DDAP or another regulatory agency to come in and make sure not only that your standards are up to care for safety and what's going on in these sober homes, but also the backside of it, where the funding's coming from to support it, who's supporting these homes. And one of the things that was such a red flag in our case was all the people in that sober home were going to one treatment center. And we were told by many people in the addiction recovery aspect that that's not legitimate. You should have a variety of people all at different treatment centers at different stages of the recovery that are in that sober living phase that should be participating. So my recommendation would be that DDAP has to be given even more authority to oversee these sober homes. If they're going to be in Pennsylvania or any state and be a registered sober home, they should open their books essentially to show.
And I would piggyback on that with just, it's one thing to give them more oversight to do it, but they need to have the resources to make sure they're doing. So if they're just going to pile more stuff on the plate and not give more inspectors and all of that to be able to do it, you're not getting to the core root of the problem.
Yeah,
right.
I have a question. Again, thanks for being here. I have tons of questions. Hopefully I'll get some more time with you all. But one of the questions I had was regarding the relaxation of regulations to support patients' needs during COVID and the explosion of virtual care, which to me seems just prime for abuse all over. Are you seeing any of that yet? And has any of that come towards your desks?
Not in the treatment realm. I'm the chief of the insurance fraud section, so we've seen it in other aspects of that, but I haven't seen any increase or anything with the treatment realm.
And that was my follow-up question. Have you seen any parallels in other sections of healthcare where fraud has existed like it has within substance use treatment?
No, this is such a just mass all once kind of thing that everybody's trying to play catch up, not only to regulate or to protect, but even the insurance companies. And that was, I'm not on the side of the insurance companies, but they saw the fraud and they identified the fraud, but they couldn't do anything about it because of the way Obamacare and the ACA was set up, where if they were able to step in a little sooner or have the ability to cut some of that funding off, it would have probably prevented a lot of this.
I mean, I think once they became aware of it, they were able to stop the payments while they were doing either their internal investigation or referring it to an office like ours to do the investigation. So thankfully, it's kind of slowed down at least the treatment industry. Do I think it'll probably resurface? I'm sure. But as of right now, I think it's still pretty fresh as we're still going through, a nationwide, obviously, problem with the opioid epidemic. But again, because they became aware of it and they were able to stop the bleeding eventually, I think they've been able to maintain that at least up until
now. Bill Stauffer, Pennsylvania Recovery Organization Alliance, and we really appreciate the Care Center for bringing attention to this issue. We've been concerned about the impact on recovering people and their families for years. Two questions. One, we've noticed that a lot of this has to do with out-of-network benefits. And so the idea of getting people to understand what your insurance benefits are, get information on the back of the cards about what the laws are, could be really helpful. That's part one. And part two, Florida, we watched what was going on down there. They had a specific hotline set up. I know I called it when I saw it come up our way, setting up a particular hotline for predatory services here in Pennsylvania that educated the public about this and made sure that everybody knew about it. Are those things that are on the radar? Thank you.
I don't know from the state that like DDAP, but that's something that they have as part of some of the new regulations. from our specific office, we don't have a hotline that's set up for that. And I don't think we have any plans in the near future of that. It's certainly something we can discuss with our powers that be and bring that back to them.
My name's Sarah Laurel. I'm the founder of Savage Sisters. We're a nonprofit from Philly. I'm also the founder of the Harmful Ethics Reduction Committee, and we serve Philly, Delco, Monco, Bucks, and Chester counties. We are a coalition of individuals that take anonymous reports from men and women who have received illegal or unethical care in a sober living home or recovery house. So 2 questions. Number 1, how long did the investigation that you guys did with Liberation Way take to actualize? Meaning, how long were people under their care while being investigated without being warned? And 2, we as a committee have met a lot of barriers with reporting unsafe and unethical behaviors to a degree of so many egregious things. Housing that was filled with sewer, water, sexual coercion, abuse, and trading within the household from male property owners. And we have gotten absolutely no response from local state officials. We've even drafted letters and sent them out. So my question, and I just actually spoke with DDEPS because I had the concern level is so high at this point. How do we access you?
I can start with the how long it went. I would say it was probably a 2-year investigation. However, and while we didn't notify the patients or a lot of the people that worked within the facility, I will say because a lot of the former patients and or employees and current employees came forward when they did, and we were conducting interviews, even though we asked for them to, some of them, to not go back and disclose that we were doing this investigation, word got out pretty quickly. So even though the patients were still, going to the facility and quote unquote receiving treatment, I think the biggest issue was that they were more so exploited. There were actual sessions that were going on, and there was treatment that was going on. Were the doctors always present? No. Were they having to submit multiple urine samples a day? Yes. Were those always being reviewed by a doctor? No, but I think the overall treatment was still occurring. And again, there were former and current employees who were doing the best that they could, knowing that the facility overall wasn't the greatest, but they were conducting the counseling sessions and doing the therapy and what they needed to do in order to make sure that the patients received treatment that they needed to.
I'll speak to access to us. Unfortunately, the Attorney General's office has jurisdiction in very narrow realms. Treatment centers and sober homes and stuff like that is not something our jurisdiction extends to primarily. We kind of used one of our loopholes here to investigate this treatment center as we saw the referrals, and that was the insurance fraud or the financial crime hook that gives us jurisdiction and to do what we did essentially. The reason our jurisdiction is as limited as it is because when our office was created and established, they didn't want us circumventing the local DAs and the local authorities to come in and conduct investigations like that. My recommendation is where the sober homes are located. I know you probably have done this before, but the local DA of the county is the one you want to start with. If they feel it's something they can't handle or something more significant or multi-county, they have the authority then to refer their jurisdiction to us to then get involved and investigate. That's a tough one.
So I think get a hold of the Pennsylvania Attorney General's office, insurance fraud, Medicaid fraud units, and get that tip to them. They can circle back with the local district attorney and see if they want to refer those cases. In some cases, they don't need a referral. So that's really important actually to bring out in this, not just here, but in our webinar. Get a hold of the local police, the local district attorney, and then when you don't see a response, continue to work with the state and federal authorities until you get a response. My question is, and these are complex investigations, and you do understand that if you have a police agency that gets a complaint about a treatment center, it's like there's a wow factor. It's like, I don't know that I can do this, right? And so how important is it that local county jurisdictions sort of get educated and up to speed that these cases are doable? How confident were you in the beginning when you first did your first treatment case that you could actually do this complex case? And what are your suggestions to law enforcement and district attorneys?
I mean, we're blessed in the Attorney General's office. We have several, sections that all have expertise. I'm the chief of the insurance fraud section. We have a whole narcotics section. So there are resources if I'm asking about, hey, we got this indication of drugs, this or whatever. I don't understand what that new drug is. Can you tell me? And we'll go to the narcotics people. In this particular case, there was a lot of the financial things. So we, reached out to our finance forfeiture people or whatever. Going back to kind of your question of how do you get to us, if there are insurance related and finance things, we have the website has numbers and you can drop down and refer those things. And if not, you can reach out to our general number. We try and get that out to the other, things. If it's not something we can handle, we refer it to DDAP or whoever.
Question in the audience.
Hi. Thank you. I really appreciate all the presentations today. They were incredibly informative and insightful. I guess my thought is that in listening to all of this, it's really that there's a broken system, right? And so that's what's leading to unethical practices, and that's what's leading to so many concerning things that are happening. And so, Dr. Swift, when you talk about the income statement that you created and how it was chaos, as a provider, that's what we live with. And so I wonder if that's a point of advocacy to show that to MCOs and to counties for adequate reimbursement rates. And ultimately, that's what's leading to staff shortages, which increase the need for profits because there's just not enough room for community-based providers to provide effective services. The wait lists are out of control. And so that brings me to my comment/question on, parity and equity in healthcare. And you have a lot of individuals that have commercial insurance, and they have to find these loopholes because they have to fight every day to get another day. Even if, they say, okay, well, you no longer meet medical necessity. And that person could be crying at the door and saying, but I'm scared to leave. I think I'm going to use. I don't feel ready. Sorry, you have to fail first before you can get another try. And so those individuals that are self-pay and have commercial insurance, they have access to therapy and medication, and they don't have access to some of the other evidence-based practices, such as having a psychiatric rehabilitation program, a certified peer specialist, a certified recovery specialist, and so where's the parity there? And then on the other hand, you have individuals that have Medicaid, and they're automatically approved for 30 days of treatment, which is fantastic. But there are so few providers that are willing to accept them. And so it creates this fractured, broken system. And so I guess from your perspective, where's the solution? Because when this presentation started, Mr. Shapiro said, we are the change agents. Everyone in this room has the power to make change. And so what are your thoughts on that? And where do we start?
One of the biggest disparities is the reimbursement rates from out of network and in network. If they were more closely aligned, I think you'd see a lot of this go away. The fact that you can go out and the fact that this treatment center alone would only do out of network. They didn't want anything to do with in network because they don't want to go through the regulations, and then they didn't want to go through the lower billings. The fact that that exists is one of the biggest problems for the disparity, honestly, that I think.
And I think, I forget what the exact figure was. I think it was like 3.5 times the amount of some of these bad actors as opposed to the ones that are doing it right. And that's money that's going out the door. So more prosecutions like this, and hopefully we can, shut down the bad actors so that there's more resources that are being directed to the ones that are doing it correctly.
There's one more question from the audience.
Yeah, we're here about business ethics, but business ethics is only as good as individual ethics. And your prosecution is being discussed as a prosecution against Liberation Way, which was obviously set up as a corporation. How did you go about prosecuting the individuals of that corporation? And the second part of that is, obviously, when you prosecute corporations and the individuals who essentially use the system for personal gain, how are you able to disgorge the money back from either the individuals or the company? You know, we haven't talked about what the sentencing was. I don't know if that's important, but obviously to be able to disgorge the money from the individuals who profited, how did you set that prosecution up to do that?
Okay, so couple things. One, as we kind of referenced, there was a lot of patients and current and ex employees that were able to provide us information that, hey, the CEO told me to do this. This is what he told me to do. And then we went and we were able to obtain bank records, documents, everything like that, and followed that document trail. They're telling us, hey, the sober homes are part of Liberation Way, but they're in a different name. So then we found the documentation, we found the leases for the sober homes that were set up with these false companies. And then the background of that was, all right, lo and behold, here's all our players from Liberation Way. They're just hiding in the background, making these fake companies to be able to hide what they're doing. In regard to the assets, we found out kind of maybe about halfway through our investigation, as we were just kind of wrapping up, that an equity firm had come in and had basically paid out to all the players here, including the main people. And then they had taken that money and moved them into accounts. So we went and we seized those accounts, and actually it was a interesting thing. We had some battles back and forth with the defense counsels on it, but we basically, they had them in investment accounts, and we seized them and said, all right, we're going after restitution here. We're going to let the accounts stay where they are. They can invest, do whatever. The only thing they can't do is, if they wanted to, get rid of all the money in the account, they've got to come to the judge and basically, get signed off on that. So the account stayed there during the whole prosecution, and as we went through the court system, and then ultimately, as part of the guilty pleas, that account was transferred over, and that's where the money came from to pay restitution.
Just to touch on that a little bit too, one of our main obstacles was investigating a treatment center where you have drug addicts essentially receiving treatment, possibly still using. We had to go about this completely the back way, and it was a complete financial investigation, which led us to our targets, which led us to the ones that were profiting the most and benefiting off the shoddy care and the illegal acts that were going on. So that's kind of how we identified our main players and the targets that we were going to go after. We even ran into a lot of obstacles with judges and stuff, where court orders and stuff were being obtained and stuff like that, but they were so concerned that delicate information of the people in treatment and their medical records and stuff would be in the wrong hands, essentially, that we had to take a step back, and we couldn't just go right after, like we normally would, an investigation where we subpoena the records of here or there or XYZ. We had to do it through the shell corporations and try to backdoor it in, so that it was more, it gave people, I guess, greater, I don't know what I'm trying to say, greater,
we had to ensure there's greater protection.
Yeah,
we were very conscientious of the fact that we were dealing with patients, dealing with treatment. So when we would seek records, if we needed it, that it would be part of the medical thing. So like for example, the whole urine things, we sought that. The doctor was just basically signing blank urine things for every patient, day after day or whatever, and that was going down to labs in Florida. Well, that had patient information, so we were conscientious about what we were getting so that we could, further the investigation, but not compromise patient information and stuff like that. So we worked with we were in our grand jury. So that was something that the grand jury judge and the prosecutors talked about, how we could word the requests and that so that we could cover both of those.
There's a lot of redacting of a lot of information.
I think we have time for one last question.
Hi, everyone. My name's Carrie. I'm a student here. Sorry, I missed some introductions. I just had 2 classes, but thank you for being here. I'm not really sure if this is like a question for the panel or any medical experts in the audience, but currently I'm working with an emergency pre-hospital device company, and they're making pre-filled auto injectors. Right now they're working with the usage of ketamine for the Department of Defense, but they're exploring the use of naloxone. And so just like as a more affordable vehicle for this. So my question was, when administering naloxone or any other opioid reversal medication, is a full dose administered or are the doses titrated? And in that case, why so?
I think we have Dr. Garbely might want to handle that one there, unless our insurance fraud and Medicaid
I would
fraud.
defer to the doctor on that
Yeah,
one.
they're very smart people, but I don't think any of us went to medical school. So
Thank you for your question. It was a very important question. So because of the strength of fentanyl, its congeners and its precursors, the dose of naloxone has been adjusted accordingly and oftentimes requires multiple doses. And we find that when we have someone come in who's using heroin, for instance, but it's really fentanyl, that we have to be mindful of precipitated withdrawal, because the half-life of fentanyl off the street, synthetic opioid as it is variable. And we're not dealing with pharmacists, street pharmacists, I guess you could call them. But we're not dealing with, a package insert that can help us understand how long acting this is. We're just really trying to do it through specific ways that we can see where they are in their withdrawal process. But we've had to adjust naloxone, as Steve would tell you, because of fentanyl. And fentanyl's in everything now. It's in the cocaine supply, stimulant supply, marijuana supply. So it's really a scary place we're at right now when it comes to fentanyl.
thank you, Dr. Garbely. All right, so we are at the end of our seminar today. I want to thank our panel, our presenters, and our good friends for the Center for Addiction and Recovery Education and the Pedro Arrupe Center for Business Ethics. I want to thank our students and those that have come and attended this seminar. And I want to thank those that are joined virtually. So with that, goodbye, have a great afternoon. Those joining us here, please, down the hall to the right, we have refreshments and a networking session. Thank you very much.